Welcome to the second annual conference of the Liverpool Dementia and Aging Research Forum. It's really great to have a lot of people registered for this event. We had around 250 people registering for it. And because of COVID, usually we do it face-to-face, but we thought, well, let's do it virtually. Everything's run virtually at the moment. So we're hoping that many more people are joining us. I see the numbers are rising quickly now. So if, when you're joining, if you could please stay on mute and turn your video off so you'll only see our speakers. And today we've got 10 speakers from different backgrounds. We've got academics, we've got clinicians, we've got third sector organizations represented, and we've got a family carer for someone living with dementia who will be sharing his experiences about caring for his mother living with dementia during COVID. Throughout, please feel free to use the chat box and drop your questions in there. After each talk, we will have a few minutes where we will have some question and answer time. There will be a 15-minute break at 12 o'clock as well. And then towards the end of the event, which will close at 2 o'clock, we will have half an hour breakout rooms. And you should have seen this in your registration form, and you might have received another email about this. We're having 4 separate breakout rooms. So at 1:15, we will share the links on the screen and you can decide which breakout room you want to join. One breakout room will focus on music and dementia and the benefits of music to people living with dementia. One breakout room will focus on inequalities in dementia care. The third room will focus on COVID-19 and care. And then the last one will focus on multimorbidity and aging. So as you go along through the day, maybe you want to change your preference for the room, so just click on the link when we're having those rooms. And throughout also, we will be actively using social media, so please feel free to join in on Twitter using the hashtag #LiverpoolDementia. And now, as our first speaker, I'm going to hand over to Lena O'Connell from Tide Carers, and she will be talking about her legal work and dementia care. Over to you, Lena.
Thank you, Clarissa, and thank you for inviting me to speak at the Congress. So I am here as a representative of a charity, registered charity called Tide, Together in Dementia Every Day. And let me just share my screen. I'll talk about one of Tide's projects called A Law for Dementia Carers. So I'll just talk about some findings and a sort of a short study that we carried out and some findings and what happened to them. So I am going to share my screen. I think you have made me a host, Clarissa. Yeah. All right. Let me just see what's I don't seem to see my screen at the moment.
You do have rights to share your screen, Lena.
Yeah, I'm trying to figure out. I can't see my presentation. I'm sorry about that. Not sure what's going on. Sharing, but you can't see. Can you see? I'm just opening the presentation. Can you see it now? Do you see the presentation? Right?
Yes.
Yes, great. Thank you. Sorry about that. So yes, as I said, the project is called Law for Dementia Carers, and it's part of Tide. I'll just quickly say who Tide are. So as I said, we're a registered charity. We're based in Liverpool, North Wales, Scotland, Northern Ireland, and also in Yorkshire and Humber. And we work with family carers and former carers of people living with dementia, aiming to connect them, to mobilize them, and to get their voice across and to influence policy and practice and decisions that are made about them. So one of the projects TIDE has is called Law for Dementia Carers. So it was funded by the Legal Education Foundation. It's a 2-year project, and we've completed year 1. We're in year 2 currently. It is a partnership between a Making Space, so between TIDE, Making Space, that's another registered charity, and some support from Manchester University's Dementia Law Clinic. The project focuses on legal rights of family carers for people with dementia. So originally we set out to develop a number of modules of legal training program for carers. We were going to deliver them face-to-face as a part of other activities that TIDE delivers. We were also going to develop a training program for health and social care professionals around carers' rights, and in the end produce some guidance for around legal support for carers. However, all those plans kind of were scuppered as COVID happened, and we refocused our project on finding out about the impact of the lockdown on carers' rights. So we kind of focused on caring in lockdown. Particularly, we wanted to find out about how the emergency coronavirus legislation affected carers' lives. We hope that the findings from our short study would influence the government's response to COVID-19. And indeed, we shared a full report with MPs and with other sort of movers and shakers in autumn to influence the 6 months review of the emergency legislation. So why we decided to look at the caring in lockdown? Well, we knew that the impact of lockdown on carers was expected to be severe, and this was quite clear after just a couple of weeks. And we felt that, well, the carers themselves were telling us how hard it was for them, and we wanted to gather this evidence to make sure the Care Act easements and the Care Act itself kind of are impacted and take this into account. So if you want to kind of know more about the project, you can go on TIDE's website. What we've got there is an easy read guide for about the changes of the Care Act that was prepared by Manchester University's Dementia Law Clinic. We delivered a free webinar to carers as well, focused on legislation and how it affects carers in England and Wales. The recording of the webinar is also on our website. And we joined the One Dementia Voice campaign, where we called on government through an open letter, we signed the letter, to provide key worker status to family carers so that they're able to visit and support their loved ones living in residential care. And I think you may have heard of the campaign. It was on the news, it was in a number of newspapers, so there is some information about it on TIDE's website as well. So how did we go about finding out how carers were impacted by the lockdown? So we sent a survey out to our carer members. We have over 1,000 members currently. TIDE is a membership organization. And we sent the survey to our members. We also gathered some feedback from our Facebook page, from online activities that we deliver currently, such as coffee mornings. And we also took part in the research at Liverpool University. I think Clarissa will be talking about it later. So the survey was sent out and we received around 191 responses from carers and former carers. This was followed up by semi-structured telephone interviews in the 4 nations. We carried out 9 interviews, and data was thematically analysed, and findings were collated in the reports, the easy read guides and the summaries. So more of that, as I said, is on our website. The full report is there as well. So out of the 191 respondents, 94% were either carers or former carers. And what they told us was quite sometimes distressing, their distressing experiences of caring during the first 6 months of lockdown in particular. So 58% said that that their caring role changed significantly in the lockdown, and they spent more time caring, providing care. They also said that they were not able to continue as before. Things changed significantly. And around half were not aware that they're entitled to carers assessment. And well, they were aware, but they didn't have one in place before the lockdown, and they experienced difficulties with obtaining carers assessment during the lockdown. Also, we heard that carers experienced difficulties of being heard by health and social care professionals, and also they tried to get involved in decision making about their loved ones with dementia, but often this was kind of overlooked. And it appears that a number of sort of health and social care professionals kind of were not aware of the carers' rights around lasting power of attorney and continuing to provide care to the loved one who is in residential care. So the summary, kind of our findings support earlier Alzheimer's Society study. I think it's titled Worst Hit, Dementia During Coronavirus. And it identified that carers were exhausted and spent 92 million extra hours caring for loved ones with dementia since lockdown. We did find some positive examples of carers being supported, but we also found examples of carers being isolated, abandoned, and unable to exercise their legal rights especially even if they had the lasting power of attorney and their rights to assessment. So we came up as a result with a number of recommendations that we included in the reports and shared with decision makers. In fact, some of our carers, and I think some of them are present here today, tweeted their MPs and joined the campaign, the One Dementia Voice campaign about the key worker status. So our kind of work around finding out how carers were impacted was followed up by a campaign as well around key worker status. So there are 7 recommendations in total. So we believe that there should be guidance and legislation that reinforces the carers' rights to an assessment, and reinforces that this right has not changed as the result of COVID-19. And there should be systems in place to monitor that this legislation and guidance are being followed and implemented by local authorities. We also believe that care home sector needs clear guidance about how to work with family carers and how to include them in the care of the residents and do it safely as well. The proposal was that the proposals of One Dementia Voice campaign to enable carers to be recognized as key workers should be supported. We also believe that carers, so health and social care staff should automatically include carers in decision-making processes that affect health and well-being of people with dementia, and that there should be clear guidance and standards around this as well. I think we also highlighted that staff should be reminded that carers do have a legal right to be involved in decision making, for example, when they have the lasting power of attorney. So this is a legal right that all carers have. We made some recommendations around eligibility for the carers allowance, that it needs to be revised on a temporary basis to reflect the current situation and potential other waves of pandemic. And also, we found that it was very difficult to find information about the Care Act easements that were enacted. It wasn't immediately available, and we believe that this information should be publicly accessible and transparent. We recommended that local authorities exercise creativity in meeting needs of people with dementia and carers, especially around providing alternative options for care and support where possible. And finally, we heard from carers that a lot of community support and organizations that provided support, all of that stopped during the lockdown, and there was a huge gap. And we felt that it's critical that community support activities and their ability to adapt and diversify should be recognized in this environment, and that they should be supported by health and care, social care commissioners. And these recommendations are also included in the report on our website. So I can stop here and open the floor to the questions if you have any questions around this project and its findings. Thank you.
Thank you very much, Lena. That was really interesting. Right, are there any questions from anyone? If you want to put them in the chat box. Lena, so one question for me, how do you think COVID has impacted your work or TIDE's work on the legal rights in dementia?
So yes, the original plans to produce training modules for carers around their legal rights, as I mentioned before, and to health and social care professionals. So those plans kind of were suspended. We had to focus our work on this part of basically on finding out how COVID affects legal rights. However, we are going back to the original purposes of the project, and we are developing those modules. There is a steering group comprised of carers and former carers who are going to share their expertise and review anything that we produce. So the modules will be co-produced, and now they're going to be delivered online rather than face-to-face. So watch this space. The information will be on our website, and they will be obviously free to carers, and do join them. So they will be around. They will be also reviewed and enhanced by legal professionals who work at Manchester University's Law for Dementia Carers Clinic. So they will cover in detail a number of legal rights and legal issues.
Yeah, I think you've also answered a question there from Jill Connor. Are there any plans to run the clinics online? So
yes, so it's not going to be a clinic. There will be kind of training modules, but in an easy format. They won't be very formal, very interactive. So yes, the plans are there. We're going to do them this year.
Okay, brilliant. And another question from Rachel: when do you think the training will start, and will you do it for professionals?
Yes, we will do it for professionals. Sorry, I said we're going to do it this year. We're going to start the training from next year, and the priority is to develop the modules firstly for carers and then for professionals. So second half of next year, the professionals modules will be done as well, and also delivered online.
Yeah, great. And a couple more. Will there be printed materials for those carers who do not have access to digital devices?
Yes, this is possible. This will be done on an individual basis, I think. Then do please get in touch with us, and we will make sure we provide printed materials in various formats.
Yeah. And one more question from Leah Reichertz. Would there be recommendations for organizations who support carers so we can improve our service?
Yes. I think when we create the modules for carers, they will also cover recommendations for the third sector organizations, such as TIDE itself, and for other organizations working with carers, because a number of carers who are on the steering group are also active in other organizations. So they advise Dementia United in the Greater Manchester, so they're very experienced in that respect. And there are various kind of levels of experience. Not everyone, is also on boards or in professional groups elsewhere. But nevertheless, there are carers who will be happy to share that side of their expertise, and we'll be including that in the modules as well.
Okay, thank you very much. So I'm sure if people want to get in touch with Lena, she will share her slides after the presentation as well, and there's an email address, so please feel free to have a chat with her about this. And thank you very much, Lena, really interesting.
Thank you. I'll stop sharing the screen now.
Yes, please. And now we have a very, very different topic. We've got Craig Murray from University of Liverpool, and he will be talking about how eye movement changes might help to detect dementia. So over to you, Craig.
Hi everyone, thanks Clarissa for asking me along. I'll just share my screen if you bear with me. Okay, right, I'm hoping everybody can see that now. So I'm going to be talking a little bit about how eye movements and vision in general really may be able to help us detect the signs early on of neurodegenerative disease, Alzheimer's and Parkinson's specifically. Just move along. So before I do that, I thought it'd probably be useful for me to give you a little bit of background about who I am and also what an orthoptist is, what orthoptics as a profession is, because that's something that not a lot of people have heard of unless you've come across one, either in work or as a patient. And then I'll talk a little bit about how eye movements can potentially help the early diagnosis of these conditions and hopefully raise a little bit of awareness about how patients who are living with dementia, either early on or later on in their journey, could benefit from intervention from some of these particular eye conditions. So first of all, what an orthoptist is, we're an allied health profession. We are part of the ophthalmology team, so ophthalmologists, consultants, eye care specialists, optometrists and opticians, we're part of that team. We work within the hospital primarily, and our specialty is the diagnosis and management of eye movement disorders and visual function problems. And we see patients right from cradle to grave is the usual kind of expression. We see newborn babies right the way through up to adults and elderly adults and all of those in between. So I'm a lecturer and currently the Director of Studies for the undergraduate orthoptic programme at the University of Liverpool. So my primary responsibility is to train up the orthoptic workforce of the future, if you like. But I also have an honorary contract at Aintree, and my specific research interests are around neuro-ophthalmology. So you can see a couple of them on the slide there. More recently, my interests have been along the lines of Parkinson's disease and in particular eye movements and dementia. So before I get into saying how eye movements might help, I thought it'd be useful to give a bit of a background about eye movements. So we have 5 different systems that we use to be able to get around and see the world around us, and they're divided into slow eye movement systems. So that would be smooth pursuit. So that's our ability to track an object that's moving relatively slowly in our visual world, so we can lock onto it and follow it so that we can view it as it moves through our visual world. Vergence is another slow eye movement. So the most obvious one of that would be convergence, so the ability for you to move your eyes in and look at the end of your nose, which is obviously quite useful if we're wanting to read. VOR, which is the vestibular system, so that's our eye movement in response to our head moving from side to side, because obviously we're not static, our head is constantly moving and our eye movement system needs to continually correct for that type of movement. And we also have fast eye movements, and they are called, technically they're called saccades. So that's our ability to move from one target quickly to another, and that can be in response to a visual stimulus quickly suddenly appearing in our visual world, or maybe sound. So there's a loud bang in the distance and we turn to look at it. So not only does our head move, but our eyes will move also. And finally, optokinetic nystagmus is a combination of both fast and slow. But it's the fast eye movements, the saccades, that I'm going to be concentrating on today, because they are actually quite useful in the in identifying certain characteristics that could help us identify many diseases early, and that would include Alzheimer's and Parkinson's. So on the slide now, you can see quite a complicated looking graph. All this does is basically show us what a saccade is made up of. So the various parts of the saccade are the velocity, so how fast we can move our eyes into a particular new position. The amplitude, that is how big the saccade has to be. So to get from position A to position B, how far our eyes have to move is the amplitude of the saccade. And then the latency, which is like the delay or the reaction time from the stimulus appearing to us making the movement to move our eyes to that new position. And you can see on this first graph here, we can get a good readout from quantitative eye movement. So in actually measuring all of these parameters of the saccades, we can get an idea of what the latency is, the peak velocity, so the top speed, if you like, of the saccade, and then the amplitude. And then this second graph is quite useful. This is called the M sequence of saccades. And all that basically shows us is, you can see this quite positive correlation between the bigger the amplitude, the faster the saccade has to be. And that is really a key element of saccades, and it's quite a uniform response. So in any patient or any person who doesn't have an underlying pathology, an underlying eye movement problem, we can quite easily, quite comfortably predict how fast a saccade should be in response to the size of the saccade that is required. So how do we assess saccades? Well, you can see on the photograph here, in clinic, this is how we would use the assessment of saccades in a qualitative point of view. So quite simply, the orthoptist would hold up two different coloured targets and either ask the patient to look from the red to the white, in this case, in sequence, or instruct them to do that on their own without a verbal command. So that's a qualitative way we would do it, and the orthoptist would watch to see, do the eyes look as though they're moving as they should? Are they making the full movements? Do they look slow? But that is qualitative. We can also quantitatively measure those saccades, and that requires some specialist equipment. Up until relatively recently, in order to be able to actually quantify the speed and the size and the latency of the saccade, you needed quite a big lab with quite a lot of specialist equipment. But we've now got this portable testing equipment, which you can see on these two bottom pictures here, with this head-mounted device called the saccadometer, which projects laser points onto a wall, and the subject just looks from one laser target to the other in sequence, or however the experiment is set up. And then this records the speed, the size, and the latency. And it feeds it all into a computer and then spits out all of that information. So quite easily and quite simply, we can put a quantity on some of those quite important measures. And the reason saccades are quite useful, particularly in neurodegenerative disease, is because, as you can see from this diagram here, there are many regions of the brain that are involved in the initiation and production of a saccadic eye movement. So from the point at which a new visual target appears in your visual scene, a sequence of events kicks off as soon as you recognize that new visual target. And all of these areas of the brain, represented through these connections on these red lines here, start to talk to each other and send signals to various other parts of the brain. And because this involves so many regions of the brain that are then affected by pathology such as Alzheimer's or Parkinson's disease, problems in the initiation or certain parameters of the saccades can give us indications early on that there might be a disease process beginning to take hold. So we can test visually guided saccades, so they're reflex saccades, so a new target appears and we make a saccade to that new target, and as I've already said, we can do that to command, to a verbal command, or we can get a patient to anticipate where the new target might be, or we can get them to look to a point in the visual scene where a target had been and then had disappeared. So they've got to use a memory guided saccade to look to that position. Or we can test what are called anti-saccades, and they, along with the memory guided saccades, require a little bit more cognition, because an anti-saccade is where we get a participant to look to the opposite direction to where the new target was. So if the target appears on their right, we ask them to make the same size saccade to the opposite side. So that involves us overcoming our instinct to look at the new target and then producing the saccade in the opposite direction. So it requires a little bit more executive control. And saccades in neurodegeneration has been quite well described within the literature. You can see on the slide there, in Alzheimer's disease, for prosaccades, so those saccades looking towards a new visual target, we get increased latency, so the delay time between the target appearing and then the saccade being initiated can be a little bit longer than in patients or in normal controls. Anti-saccade, so where you've got to make the opposite movement, you get more errors, and that's been shown to correlate with a decline in cognition also. Parkinson's disease, again, the anti-saccade, because it involves a little bit more executive control, you get increased error rates. And there are slight differences between Parkinson's, Lewy body disease, and Alzheimer's disease that has been shown through the assessment of saccades. So it might be a way of differentiating between those particular types earlier on. And in mild cognitive impairment, we get similarities to mild Alzheimer's disease. However, again, there are some differences where the latency can be normal in the mild cognitive disease. But most interestingly, the difference between amnesiac and non-amnesiac mild cognitive impairments can show where there may be an indication that there could be progression to Alzheimer's disease. So these are things that have been fairly well described within the literature around eye movements. And some of the other visual function parameters that can be affected by the disease, these diseases, can include visual function. So visual function would be things like your visual acuity. So if you've ever been and had an eye test done where you're asked to read down a vision chart, that can be affected by these diseases also. And contrast sensitivity, so your ability, as you can see on this chart here, to discern a slightly faded out letter as opposed to a completely black on completely white, could be an indication that there's some retinal and cortical cell loss being caused by these particular diseases. So again, it could give us an indication that they are the early signs of the disease process with these tests. Another test which was in the news quite a lot a few years ago was the ability of something called OCT, so optical coherence tomography, which is a test that is really simple to do, non-invasive, and you may well have had done yourselves if you've been to the opticians. So this is basically a scan of the layers of the retina, and the certain characteristics that might indicate early signs of neurodegeneration with this particular type of test. So you can see on the scan here, these are the layers of the retina, and one of the layers in particular, so the retinal nerve fiber layer, all of these fibers travel all the way back down the optic nerve to the ultimately into the brain. So where you get early disease process, you get early effects on these structures, that will have an impact on visual function, and we can actually measure these particular parameters and get an indication of early disease. And then finally, in terms of the types of problems that may be caused by the disease, this other one is binocular vision. So this is our ability to use both eyes together as a pair. And the top grade of that would be to see things in 3D or stereopsis. So a study we did, we looked at a small group of Parkinson's patients to see what type of binocular vision problems they had. And you can see from the graph here, reduced NPC. So this is a patient's ability to track an object and converge, as we said before, can be quite often reduced in Parkinson's patients. And the decompensating phoria that is the ability to control both eyes together, starts to degrade over time. And what this can actually result in is symptoms that the patient may well be suffering from quite early on. So those symptoms can actually be quite debilitating for a patient. So we can have, these patients may suffer from reduced vision, eye strain and double vision. So in them trying to keep control of their binocular vision, that may cause them some discomfort, particularly over a longer period of time. And once they start to lose control over their binocularity, then they may well start to suffer from double vision. And obviously that's going to have an impact on their quality of life, but also, particularly in a more elderly age group, they could well therefore be more at risk of falls due to their, particularly the double vision. But we can intervene with many of these problems. So you can see from the photograph there, so Jeremy Corbyn a couple of years ago was in the news quite a bit, lots of comments on what was on his glasses. Well, this was a Fresnel prism, which is a really simple stick-on device that we put on for patients who are suffering with double vision in order to join their double vision up. Obviously, he was using this for quite some time. These are things that orthoptists are able to offer to be able to help patients and can improve very simply, quickly improve their quality of life. And we can also give exercises for certain patients to try and help them keep control of their binocularity. So there are things that we can do to help these patients. The other elements of what I'm wanting to look at also is at the moment there's been no comprehensive study of all of these different parameters, so visual function, eye movements, to look at a potential biomarker for particularly Alzheimer's disease development. These tests are cheap and they're non-invasive, and the early diagnosis of the disease can obviously have an impact on a patient's quality of life. So what I'm proposing to do, but as with lots of things at the moment, this has been slightly scuppered by the current pandemic, is to look at eye movement and visual function in groups of these patients and compare them to healthy controls of similar ages to really pinpoint these characteristics in this group of tests to see whether these do offer a potential cheap and non-invasive biomarker for identifying the disease. Hopefully going to be looking at saccades, OCT, visual acuity and contrast sensitivity. So some of the items that I've highlighted in the talk previously. And I want to look at patients who have a diagnosis of amnesiac mild cognitive impairment, non-amnesiac, and those patients with early onset and early mild decline, and compare all of these outcome measures to healthy controls. So I'm hoping that I've, within this talk, highlighted the need and the option that patients have for up-to-date vision assessments to make sure that some of these symptoms, which could be intervened with, very simple mechanisms to help them keep control of double vision or help them with their visual acuity. And many patients we often find come in, and it's not just exclusively to dementia. Many patients being seen for other debilitating diseases come to us and they've not known before that they could have had something quite simply done to help them with their visual problems, and that will improve their quality of life. my plan is to obtain a PhD fellowship to look at this particular study and put it into practice and see if we can find these biomarkers in this group of assessments. And obviously always open to collaborative links and welcome any interest or involvement in in this project from clinicians or patients. Hopefully as the COVID cloud starts to lift, things can start to move forward. Thank you for listening. You can see my email address there, so I'll open the floor to any questions.
Thank you very much, Craig. That was really, really interesting. So we've got a few questions. So I'm not going to ask a question first. I'll look at these first. So Marnie has asked, do you think that issues with saccades in dementia might contribute to object recognition and nosognosia?
Possibly, yes. One of the elements of research is not just the saccades themselves, but the cognitive involvement of the different types of tasks that a patient may have to do. So in particular, memory and memory guided tasks. But yes, definitely saccades could well contribute to that.
Mm-hmm. And Andy's asked, are there any inpatient wards which are visited by orthoptists?
Not that I'm aware of, not for dementia specifically. I think stroke patients many years ago, we've had a battle to get orthoptists recognised as part of the multidisciplinary team, and now orthoptists kind of routinely go into stroke inpatient wards, but not that I'm aware of, no. And I think that might be you know, an area that needs to improve. And I think it's just people are just not aware that there's quite simple things that can be done to help these patients. So that's you know, something that's not done, but it probably could be in many areas.
Yeah, and Leah is asking something that I would have asked you as well. So great implications for diagnostic pathways to improve. How would a person obtain an orthoptist assessment?
Really easily through GP referral or from the opticians. But if you've gone to the opticians and the optician has recognised a particular binocular problem, they should be referring them into the orthoptic services in the hospitals. Not all opticians would do that. Often they try to treat them themselves, but the particular binocular problem should really be referred into the orthoptist. But you can request an orthoptic appointment at a hospital like you can request any appointment. So referral through your GP would be the easiest way.
Okay. Would there be a possibility to include it in a memory assessment as well? So memory clinics.
Possibly, yeah, but I think that's where we're at the moment. Is obviously the awareness is probably quite low that it could be involved, which, you know, part of my reasoning for doing this project really.
Yeah, no, definitely. So we've got Graham. He said, I see a lot of what I believe is Charles Bonnet. Is there any diagnostic tools we can use to confirm the same? It's never very clear cut.
Charles Bonnet, something slightly different. The assessment for Charles Bonnet may include saccades, but it's a slightly different assessment, slightly different mechanism than what we're looking at for this.
Yeah, and one last question from Sue. You talk about eye exercises. Would these be generally useful when working with people living with dementia?
It would depend on the patient really, and it would depend on, obviously the eye exercises would only be used for certain types of complaints. They wouldn't be necessary. It wouldn't be that we would give exercises to every patient. They would be, and this is where you would need to be referred to an orthoptist to make that determination as to which patients would benefit from those exercises. Obviously, it may be of more use in the earlier stages of the disease because it involves the patient, you know, being able to undertake those particular exercises. But that would be dependent very much on each patient on an individual basis, really. Yeah,
great. I'm mindful there's a couple more questions, but we need to move on to James Watson. Thank you so much, Craig. That was really interesting. And if anyone has any further questions, feel free to drop Craig an email.
Yeah, no problem.
Okay, thank you very much. So now our next talk is by James Watson. He's currently doing a PhD on inequalities in dementia care, which is his topic of the talk as well. So James, over to you.
Thank you very much. I'll share my screen. Hopefully everyone will be able to see it. So I shall make a start. So as Clarissa mentioned, I'm James. I'm a second year PhD student. I'm based in geography and planning. My PhD is looking into dementia care pathways and inequalities around those. So it's based on where somebody lives, their personal characteristics, their background. My PhD has the intent of giving clinicians, in conjunction with people living with dementia and their carers, the information to make person-centered decisions to promote kind of the optimum level of care and the most positive potential outcomes for people living with dementia. So today I'll be presenting a piece of work myself and my supervisors, including Clarissa, got published a couple of months ago. It's a systematic review, and systematic reviews kind of synthesize the existing evidence on a topic. So this paper investigated how research around the world has used data sets already in existence, such as GP records, to try and understand inequalities in parts of dementia care pathways. So why is it important to understand inequalities in dementia care? So by 2040, it's expected that the number of people living with dementia in the UK will double, and the associated cost of that to health and social care would triple. With the greatest increase projected to be among people with severe dementia. And these increases will obviously place an extra pressure on already stretched health and social care services. And without a health and social care system designed to cater for the greater need, it's likely to result in greater unmet care need. Further to this, inequalities in dementia care already exist, and these are likely to be exacerbated by any issues going forward in terms of care supply. During times of restricted finances and pressured staff and services, it's important that we identify and understand the inequalities in dementia care pathways. And one way to do that is to use data that already exists, such as those I'll be using in my PhD going forward, so that we can kind of uncover a wider picture of care and the issues that can be presented for people. So as I mentioned, the aim of the systematic review was to evaluate the research that employed these kind of data sets, so we can get a global picture of how inequalities exist in dementia care pathways. We hope to use this knowledge to then enable improved person-centered care. So how did we do the review? We identified this as the first systematic review identifying research which used routine and cohort data sets to explore inequalities in dementia care. But firstly, we needed to try and define our topic and decide how we would search for the data in the area. This is all a bit technical, but there's some guidance called Prisma, which gives you the opportunity to have a checklist of the things you should be including, so that people can, so that you're transparent in your methods, so that people can evaluate your findings and the strength of what you deliver. Systematic reviews should be novel and synthesize the knowledge, so they should be new. They shouldn't be copying what someone else has done, or it should be enhancing or generating new knowledge. So initially we searched for papers. Myself and Clarissa independently assessed these, firstly by title, then abstract, then by reading the entire paper itself. We identified 27 papers which used routine data sets to investigate inequalities in dementia care pathways. They included papers with then quality rated by both of us, using a National Institute of Health Quality Assessment tool. Data was then extracted based on the stage in the dementia care pathway it related to, and the socioeconomic and personal characteristics it investigated, which could impact equality or inequality. So what did we discover? We found 27 papers, as I mentioned. Mostly they were based in the Western Hemisphere and in high-income countries. So one drawback is that this may not be applicable to middle or low-income countries or countries outside of North America or Western Europe. They do, however, highlight issues for patients and carers in dementia care. and the inequalities that arise as a result of socioeconomic factors such as deprivation or income, and the protected characteristics such as gender, age, ethnicity. So we extracted these 27 papers and formed narrative findings and synthesized the results based on the socioeconomic factor or protected characteristics they researched and the stage in the pathway they're related to. In our review, we found that various factors impacted dementia care and the quality of it: age, gender, ethnicity, the presence of and relationship with an informal caregiver, the person living with dementia's marital status, their location of residence, and socioeconomic deprivation and income all impacted health and social care interactions, people's service use, the need for formal care, and the progression of their dementia and symptoms, as well as long-term survival. Our review also demonstrated the benefits and potential of using already existing datasets, which negates the time spent and effort spent in trying to derive new data. And it also highlighted inequalities in dementia care, which we hope will enable policy change and evidence improvements in care. With routine data we have applied of actual interactions for people with health and social care, and use of such data can be incredibly valuable and cost effective. So what do our findings mean? Finally, as a result of what we discovered, we made several recommendations which we believe could improve dementia care, create more equal access and care quality, but also generate more knowledge and a greater evidence base around dementia care pathways and inequalities. So there were 4 primary recommendations. So there was providing more equitable, accessible, and culturally appropriate services for people living with dementia and their carers. Secondly, improve health literacy, increase provision for early diagnosis, and provide greater home care services to reduce dementia care inequalities. Thirdly, to conduct more research into how protected characteristics in someone's background can impact their care experience. And finally, was future research needs to encompass a more holistic view of dementia illness trajectory. So the different stages of the pathway need to be combined into one. And also the related change in care needs as a condition progresses or somebody moves through the system. So thanks for listening to me ramble on. If you've got any questions, please feel free to ask.
Thank you really much. Thank you very much, James. That was interesting. But I'm biased because I'm your supervisor. So, but no, thank you. So we've got some time for some questions. So Jack from Liverpool Dementia Action Alliance has already asked where can he download the paper. So that's good.
Yeah, I can put a link in the chat box if you want. The paper
yes, that'd be great.
Available. Yeah, of course.
Yeah. Is there any other questions? So also to highlight, we will be having a full half-an-hour chat about inequalities and dementia care in one of our breakout rooms later. So Fiona's just asked, would there be any addition to this likely on how people are treated in hospital? So I suppose inequalities in the hospital setting, James?
There are inequalities in terms of the services people access. So as I mentioned, the likes of age, gender, ethnicity can all impact whether somebody uses emergency care more or they require more urgent care. But whether that's an issue in itself or it comes as a result of people not being diagnosed early enough or at all, and then they're presenting later on when the symptoms are more severe, say, that tends to be the issue, that people who are at the sharp end, if you like, of social or economic inequalities are presenting at a later stage of their illness and therefore need a more emergency care rather than being cared for in the community.
Yeah, so they reach the crisis point, don't they? And then, yeah. So really there are inequalities throughout the whole pathway, aren't there, James?
Yeah, it's pretty much from start to finish. Before someone's even diagnosed, there are inequalities in access and a diagnosis, which obviously is the first stage in then getting on and receiving support in the community. Yeah.
Yeah. Okay. Thank you. So we'll have a proper chat later on, James, with everyone who's joining us. And now, again, we have a very mixed array of talks today, but I think it's nice to have different topics and different speakers. So now we'll hand over to Kym Ward, who is working at the Brain Charity, and she's been running singing and dancing groups for people with dementia and their family carers. And she'll talk about that and how COVID has affected all this, I believe.
Hi, thanks very much, Clarissa. Just going to do the awkward sharing screen moment. Let's go. Is that good? Yeah. Okay, so yeah, thanks very much for inviting me, and thanks to the University of Liverpool for organising this conference. It's great. As Clarissa mentioned, my name is Kym Ward, and I've been working with the Brain Charity for the past couple of years as Dementia Project Coordinator. The Brain Charity, for those who are a little bit further away from Liverpool, is a local charity. It's based in Liverpool on Norton Street, and we offer emotional support, practical help and social activities to anybody with a neurological condition, so not just for people with living with dementia. We also support family, friends and carers along the journey from diagnosis to living a full life, as full a life as possible. So we support all kinds of neurological conditions, including stroke, brain injury, dementia, as I mentioned, cluster headaches and many more specialised injuries and conditions. So in the past, it was thought that if you listen to classical music, you'd be very intelligent, and that classical music would improve brain activity and it would improve intelligence. And we know that that's not strictly true today. It's any form of music can influence brain activities. It can stir memories and it can reach people living with dementia for sure. Contentiously, even the Sex Pistols would do the trick if that person came of age listening to the Sex Pistols. When we listen to our favourite music, different parts of the brain light up, and many parts of the brain are engaged and activated. So if you're a musician, it's a high activation level of the brain. If you listen to music, it's slightly lower, but it does engage the whole brain in total. So from the frontal cortex, which distinguishes the intensity of musical emotions, to the cerebellum, which stores physical movement and movement memories. So the effects of working in a therapeutic way with music on people living with dementia can be vast. In the early stages of dementia, we see improved memory and responsiveness to memory prompts. We can also find music can lower agitation and improve cognitive skills. And in the later stages of dementia, we use music-based therapy to reach people where speech no longer can reach people. And for many people, obviously, the emotional memories which are stored up in music, they don't fade over the lifetime, so they can still be accessed in later life. Right, so we started the music-based therapy workshops in December 2018, and they ran to March 2020. And we're still up and running, but we have to obviously take on radically different forms now. So Music Makes Us is the name of the workshops, and it's an initiative which brings the music-based therapy to various different groups. So we work in care home settings, and we work in community outreach, we work in daycare centres, and we also host workshops ourselves in different locations, which will then invite just anybody living with dementia and carers too. Altogether, we've run 5 blocks of workshops. So a block is 12 weeks, and it's completely free for people. You can access the 2 streams of workshops, and so one of the streams is singing and speech and language therapy, and the other stream is physiotherapy and dance. As you can see here, we've had about 100 participants. That was up to March 2020 in the singing and speech and language, and about 138 in the dance and physio. So what do we do in the workshops? I put together a really lovely team of workshop leaders. So the physiotherapist and the dancers worked together, did a lot of research and kind of one-on-one work that explored how can we integrate physiotherapy into we looked at how to improve functional motor activity, and we looked at how to improve agility. And the benefits of this is obviously, you know, it's not just for people living with dementia, but it is for all aging people. And what we want to do really is reduce trips and falls. So we look at weight transference, how to walk. We look at different kind of cueing movements. We look at like lifting the foot up over an object, and also mirroring and balancing coordination. That sounds all very dry when I say it like that, but actually in the workshops, what that really means is people have got their hands up over their heads because they're shaking the shakers for Harry Belafonte, or people are doing a tango in a chair with a massive kind of elastic scrunchie which stretches around the whole group, you know, so their arms are up in the air waving from side to side. And we do work on the back of a chair or with a partner, or when we do it in the dance workshop, we do it at the bar, and that will help for people to stand and do really, you know, like naughty things like hip rotations to rock and roll music, which everybody loves doing, but it'll give a bit of stability as well. So we've worked very closely together with the physiotherapists to produce those routines. Likewise, in the speech and language therapy workshops, we look at respiration, so we look at breathing. We look at trying to kind of improve posture while people are sitting in chairs, because often you can find that, especially in care homes, potentially it's not always possible for care home staff to get people to sit upright for the whole day, and people get slumped over. So we look at the diaphragm and breathing. We look at how to produce words, so different kinds of consonants and vowel production. We do quite funny exercises with the face, which try to exercise facial musculature, and we look at swallowing, because obviously there's a lot of issues with dysphagia for people specifically living with dementia. Again, it sounds quite dry, but actually it's really, really enjoyable. And we do lots of kind of older songs in the speech and language therapy workshops, integrated with the exercises, and then we kind of belt out tunes, which is absolutely beautiful. Yeah, like everybody else, I'm sure, who's going to be speaking at this conference, COVID-19 and a couple of lockdowns have significantly changed our the format. So this is just a brief timeline, but we had the last workshop sessions on the 11th of March, and then we just decided that it was just too risky. That was prior to the government putting a nationwide lockdown in place. We just, you know, working in the healthcare sector, you just really have to make sure that the participants in your workshop, the most vulnerable people, are protected first and foremost. We're a small charity, so at the beginning of April we decided that we needed to concentrate on food deliveries. So we paused basically all activities across the charity, and we just concentrated on supporting some households in Liverpool which were experiencing extreme poverty and couldn't get food delivered, were shielding, or couldn't afford food. So we focused on that between April and August, and then in September we started a trial doing some workshops online, and we found that there was a few problems with that, or challenges I should say, really, especially for people living with dementia, especially to kind of be integrated into care homes. It's not always possible to have the concentration to support a whole 40-minute workshop online, and so we initially cut it down to 2 or 3 songs, and then we realized that the people that we were working with were asking, can we see this again? Can we do this workshop again, and can we do it in our own time? So we've now decided to film all of the workshops that we've been doing, all of the routines, to translate them into video form, and then to run 12-week therapy sessions, which will be where people will be supported through these therapies, but will fundamentally have the videos every week that they can watch. Okay. It was a difficult time. It still is a difficult time, obviously. The governmental guidance, it fluctuates. I'm sure everybody has their own emotional response to that, and also in terms of planning and delivering care packages, that makes things tricky. But we obviously have to do the best that we can for people who are in need. So in the care homes, visits are severely restricted still. There are time slots. They're often through a partition or a window or behind a kind of perspex screen. In home settings, we know people missing social support. We know that people with dementia and carers are feeling worse and do still need one-to-one contact or the kind of engagement which comes through those workshops. And we know that the remote support isn't the same. So we've adjusted now our services as best we can. And one of the things which I've decided for this series of workshops that we'll be doing, the video workshops, is that people will have access to the therapist. So for that 12-week period, we'll be able to put people in telephone contact really with the speech and language therapist and with the physiotherapist, so that they can, so that we can support them properly to do these exercises. One more thing that I just thought to mention, as Lena was talking from Tide, thank you for that presentation, because it is important to think about carers and the burden as well. We've discovered that obviously there are higher rates of anxiety being reported, and so during these 12-week therapy video sessions, we'll also be addressing anxiety, not only for people living with dementia, providing some exercises and providing some tips for carers as well to deal with their own levels of anxiety. And then simultaneously, the Brain Charities managed to get a little bit of funding to purchase some technology, so we can actually deliver that to people's homes to set them up to do these workshops, because we know that people need support in this as well. And obviously most importantly is just continual awareness raising and reaching out, and not kind of falling back on just thinking that a technological solution is going to be the only solution. We still need to try multiple avenues. That's the advert part of the slides. So if you'd like to register for the weekly sessions when they're launched, then please email Kym at thebraincharity.org.uk. And if you have any questions or comments, then I'm also super happy to hear them. Thanks very much.
Brilliant. Thank you again, Kym. Really good. And I know you faced lots of difficulties with COVID, so great that you could adapt it. Yeah. So we've got a few questions on the side, but please feel free to just pop them in a chat box and we'll pick them up. So Brian is asking, when doing these workshops in care homes, what was the response from care home managers and staff? Do the staff get engaged with the sessions?
Yeah, that's a very clever question to ask, because often I think that when charities or organisations go into care homes, it's kind of seen as oh right, this is a free hour or something, so that the care home staff don't have to participate. So we are a little bit strict, and we heavily encourage care home staff to get involved. And the pickup on that is, as you might expect, there are some care homes who are absolutely brilliant, and they have care home activities coordinators who basically already reached out to us when they heard that there were free workshops taking place. They were like, okay, we're going to have some of that. And obviously those care home staff, you know, are I should have done the worst first and the best second, sorry, but the amazing, one of the amazing findings or results that we had from those workshops is that the care home staff in good, active, participatory care homes, they started to walk through the rooms when the workshops weren't taking place and just sing little snippets of the songs to people. And we had residents answer back in song, which is just like, it's just so beautiful, because for me that means, okay, that really did work. The workshops instigated a different level of communication, a different mode of communication, and that just for those kind of seconds or minutes that takes place, everybody is on the same page. You know, that's wonderful. Okay, there's also the care homes who do think that It's an hour worth of free time, and they're the ones that are the most stretched, that have the least resources. And so one of the things which as strict as you can be with, like, you must take part, the care home staff must take part. You also have to understand that probably you're looking at care staff who are stretched, you're looking at care homes that just don't have those resources. And so I wouldn't withhold the workshops from those care homes, because they're in need as well.
Yeah. We've got a comment by I think it's an acronym. This sounds fabulous. I work at Warrington Hospital, where we have a 21-bedded acute ward that specialises in delirium and dementia care. Is this something that we could have a conversation about?
Yes, yeah, definitely. We've been approached by a couple of different hospitals as well, and obviously that was beginning of this year. So we are, we're in conversation with someone. Of course you can. Yeah, please get in touch. It's Kym@thebranecharity.org.uk. There you go.
Great. And then we've got a comment from Hilary. If you know if there's any similar activities in other areas of Lancashire.
I can certainly have a look. I mean, I think actually the next speaker will probably have a little bit more information on that, because they've got a massive network of different music activities. So yes.
Okay, great. So lots of positive comments, Kym, here. So, and as you've just nicely linked over to the next speaker, so thank you very much for sharing your work again. That's great.
Thank you.
And now we have a related talk by Grace Meadows from Music for Dementia. Welcome. Really nice to have you here.
Hi, thanks, Clarissa, and hello, everyone.
Yeah, and over to you.
Lovely, thank you. I'll also do that little moment of let me share my screen. There we go, okay. And that was a fantastic presentation from Kym, and really heartwarming to hear the work that she's doing, and those transformational moments that she talks about in terms of it being converted into something that becomes owned by carers, as opposed to something that they feel is being done to them. So we'll get into a little bit of that in my presentation, but I'm delighted to be with you all, and congratulations on such a fantastic conference. So I'm talking to you as the Programme Director for Music for Dementia, and I'll say a little bit about the campaign in a moment. I'm also a music therapist and have worked across a range of health and social care settings, so couldn't be more passionate about the power of music, so you might pick up on that in this presentation. I'm kicking off with this image of Nick and Paul, because they have really done so much this year in telling the story of the power of music for people living with dementia, and they've certainly really pushed it up the agenda. And for those of you who didn't know about Music for Dementia before, you might now do because of them. So Music for Dementia, I won't linger on this, but we are the national campaign to make music available for people living with dementia, and we passionately believe in making music available for people living with dementia, because we know, as you all know, there is no cure for dementia as yet, but we have an obligation to help improve and enhance and enrich the quality of life for people living with dementia. Because you have dementia, it does not mean your quality of life should suddenly fall away. And we know that music is a really powerful way of making that happen, as Kym has beautifully demonstrated in her presentation. So just to outline our mission then, we believe that everyone living with dementia should have access to the right music for them at the right time and in the right way. So it's not, as Kym was talking about, a silver bullet, you know, that you just pop the radio on and suddenly you're doing music for people living with dementia. It's not about that. It's about, we'll get into this in the presentation, it's about really understanding the individual, their preferences, what music matters to them, how they like to experience it, why it matters to them, and when they want to experience it, and how it can then enhance and enrich their day-to-day living. So what do we know about music? And I know that Kym has already very helpfully talked us through some of these. So music helps with psychological and emotional well-being. We know that the science shows that music alleviates symptoms such as agitation, apathy, anxiety and depression, reducing the need for antipsychotic medication, resulting in improved quality of life across the spectrum of dementia. And in different forms can be a supportive tool at all stages of someone's dementia journey. And actually later this month, we're hoping to launch the musical dementia pathway. So hopefully we'll be able to share more news with you on that in the coming weeks. We also know that music helps neurological functioning. Again, Kym outlined this beautifully. So engaging in music can stimulate and exercise auditory, cognitive, motor and emotional processing, because music is processed across the whole brain and not just in one area. And it can help to facilitate communication. So when words are too much, not enough or no longer available, music provides an alternative channel for non-verbal communication that's creative and enables self-expression. And this then supports sense of self, identity, agency and control. And we also know that it supports social connections, helps people to connect to themselves and those around them, and helps to maintain and sustain relationships, enabling people to be seen for who they are beyond their dementia. And for me, that's really critical, actually. And that's really what can come to the fore through good musical care. And of course, it's not just something that benefits people living with dementia. Music is also there to support carers, and it supports them in how they manage and connect with the person that they're caring for, and enhances relationships and connections in the here and now. So it's not just about memories. Memories are a very useful tool, but it's about how we use those memories to facilitate the connections in the here and now, and enabling people to really be together. But people aren't all aware of the benefits necessarily, although we know that there's a big shift happening around that level of awareness, and it's not yet a standard or required part of dementia care, and that's what we're campaigning for it to be. But this is changing, and you know, people like Kym and her organisations, and seeing some of the comments in the chat, you know, you are part of helping to make that change happen. And we saw that recognised last year when the National Institute for Health and Care Excellence acknowledged music therapy in their updated quality guidelines. So why music and personalised dementia care? Why does this matter so much? So we've touched on some of them, but it's the connection and communication that music provides. And we know that that is so fundamental, as that's one of the key things that gets stripped away through dementia. Seeing the person for who they are beyond their dementia. We all want to feel valued, validated and heard, and I think music really enables that to happen. This point feels really important as well, enabling people to be contributors and not just recipients of care. None of us want to have stuff done to us. You know, we go through lots of experiences in life, and when we do need greater support around us to help us live, there's something incredibly empowering about enabling people to give back and not just have stuff done to them or being recipients of care. And all of this feeds into quality of life, and we all deserve and want a level of quality of life that really lives up to what we want to be experiencing. And music meets the principles of person-centered care. And ultimately, people and relationships, well, that's what music is all about. Music's all about people, it's all about relationships and conversations and dialogue. So for me, it all just marries all those things together. So I won't go into this in detail, but many of you will be familiar with the personalised care model that the NHS produced. And what we did was we took that and made a musical personalised care model out of that, and that everybody can have a universal experience with music. We are all inherently musical beings, regardless of whether we consider ourselves musical in the technical sense, but we all each have our unique relationships with music, and it's how we work with those through these different levels of intervention, be it, you know, on a very day-to-day basis. You know, that singing that you talked about, Kym, that somebody does as they walk through a space, listening to a playlist, right through to using bespoke interventions such as clinical music therapy to address specific psychological or emotional issues. So how does music help to deliver personalised care for people living with dementia? Well, it really helps to value and respect people for who they are, and helps in the delivery of care for them and treating them with dignity. It helps us to see people as individuals with unique needs. You know, if we take this idea that not one piece of music fits all, you know, which for me, you know, is such a crazy idea anyway, you know, because we each have our musical loves. You know, it really helps us to see people as individuals with unique needs. But it also by understanding people's music and their musical preferences and their musical heritage and culture, we get to see the world from their perspective, and that's a really unique position. And music also helps us create positive social environments in which people living with dementia can experience relative well-being through care that promotes the building of relationships. And again, you know, over the last 7 months, as Kym talked about, we've seen people really transform innovatively and creatively those opportunities from in-person to online. And I very much hope that as we move back into what might be some sense of normalcy in 2021, we'll see a real blend of the online remaining with more in-person services coming back to life again. But also the idea that music provides opportunities to ensure that the person has the chance to try new things and take part in activities that they enjoy. I think there's a real myth around people living with dementia not wanting to try new things, and actually through the work of Kym and the many others who provide such valuable services, we see that people are more than willing to try a musical experience, even if they've never picked up an instrument in their life before or felt that they could sing. So this is something that Kym also touched on, but why is music in care really quite important? Well, we see that for staff, it helps them to connect with those they're caring for in different ways. It's about the quality of contact that comes about through music. And again, I keep coming back to that lovely example, Kym. You know, this idea that you get these spontaneous moments of connection when music's there. You know, you drop music in and it has all sorts of ripple effects that can happen. It helps them to see the person they're caring for who they are. You know, the daily in and out of caring can sort of stop you from seeing things for what they are. And I think music can just provide a new lens and way of looking at things. And it improves the quality of the care they're offering. It can slow things down. It can enable people to take a moment and really tune into the people that they're caring for. It can enable people to work in different ways, creatively, using different tools. This helps them with morale and confidence. And it can sort of, as I was just saying, slow things down, just enable people to look at things differently. And then can also help with staff development. They learn and acquire new skills, and some of those very entrenched hierarchies that you can find in some settings can be really broken down when people step out of their sort of box really and take on new roles. And we also know environments in music change drastically when music's put into the mix. If it's done in a sensitive and careful way, you know, it can really lift the mood and the atmosphere of a space or a place. And it sets the scenes for moments of togetherness to emerge where, you know, people come together. And it can really help to create a rhythm to the day. Particularly through COVID, we found that time has taken on a very fluid feeling, and actually it has created landing moments. You know, those normal rituals that have sort of gone out the window other markers can be put in through the day, and it can create connections with outside communities, and we have seen that happen very effectively through online services. And so I should say, before I go on to talking about making music a part of your care, that we do have a musical care task force, and all of you who are interested, you're very welcome to be part of that. This is really about building the groundswell around how we make music a part of everyday dementia care, but also more broadly that, you know, we know that what's good for people living with dementia is good for all of us. So when we're talking about musical care, of course, in the campaigns context, we're talking about people living with dementia and their carers, but actually music can be used across all caring contexts. So how to make music a part of your care? I mean, I think Kym's really covered this off very well, but these are just some top line things that we encourage people to think about. If they've not been using music already, have a musical conversation. Have that with yourself. Think about what music matters to you and why. What's your musical story? And then start having musical conversations with the people that you care for and you work with, your colleagues. And you'll find that all kinds of things start to surface. And then you can start to build out from there, be that a playlist or thinking about working with organisations such as Kym's. You know, have that musical conversation. Think about what matters. to people, and why that music really resonates with them. And then talk about the musical menu of choice. So how might they want to experience that music that matters to them? Is it about a playlist and listening to music?
Well, yes, good. I'll make sure you don't.
Or is it about finding other ways of engaging with music? And we know that there are lots of online services, as Kym's talked about, but also there are things such as music therapy, that clinical application of music, and interactive and participatory music making. It's really about, I always say this, so those of you who have heard me speak before might be familiar with this idea of the right music at the right time, in the right way, delivered by the right person. It comes back to this idea of personalising the music, and that's where we really see the transformational impacts of music. And then, as Kym was alluding to, we have this musical map for dementia, and pre-COVID it listed all the in-person services that are available across the UK, as well as online services, but at the moment it's mainly virtual services that are listed. So if you're a service provider and you're not on here, I'd really strongly encourage you to put your service on here. And if you are a provider within a health and care context, or you're a music provider and you just want to connect with other services, use the map to look at what's available for you locally, and hope that in 2021 we'll be able to read this and look at the whole kind of landscape across the UK. And I think this is where we as the campaign can be very strategic, because we can be looking at where there are gaps in provision and how we can work with partners to fill those gaps, to ensure that everybody's having some kind of musical offer in their locality. And that sort of feeds into some of our policy work, but I won't go into that at the moment. And we also have our own radio station, M4D Radio. So this is an internet radio station that's available 24 hours a day, 365 days a year, playing music from across eras. And at the moment on our Mix channel, we have a Christmas program that's running through. And the idea of this is that this is something that people can tune into at any time and use it to either just enjoy music, because that's the activity that somebody wants to engage in, but also to develop out from there. It might be about sitting and taking a moment to just listen to a favourite song with someone together, and that quality of contact that might come about as you make eye contact or hold a hand, or as Kym says, you dance away in your chair. So, you know, it can be used in multiple ways, and there are appointment to listen sessions that help facilitate some of the work that Kym was talking about with her service. So this is something that that some of you might be familiar with, but it's this idea that in music, what we're trying to do is be with and not do to. So this isn't about popping on a CD or popping the radio on and leaving somebody and saying, well, that's a great experience that they're having. It's very much about having that experience with somebody, and what is created by having that experience with them, really going back to this idea of quality of life, and quality of life comes very much through contact with others. So for those of you who aren't using music in your care or aren't sure about how to go about doing it, here's a little checklist of things that you can do today. Think about your music, what matters to you and why. Have conversations about music, what matters to the music, what music matters to the people that you care for and support. Look for opportunities where music could be incorporated. Use music to support you in your work. Tune into the station, visit our website, and help spread awareness. Follow us on social media and share your stories. And what can you do tomorrow? Pop back onto the website, explore the resources that are there to support you. Start making music a part of people's care plans. Note what their musical preferences are. Explore points in their day where music could help and make a difference. Talk to your colleagues about why music should be a part of dementia care. Encourage and inspire them to be musical detectives and to incorporate music into the work that they do, and start signposting people and families to our website and resources. And what can you do next week? Contact us for more information about providers and how you can make music a part of your dementia care. We're here to help you do that, absolutely. Influence others, talk to individuals, families, staff, commissioners about making music a part of care plans. And talk to us about integrating musical care training into your staff training. We have lots of connections with training providers who are able to do that. I'm very happy to link people up with that. And then talk to your multidisciplinary teams, share knowledge, skills and resources, encourage, celebrate and inspire, and be an advocate and talk about music for dementia. So that's a very quick whistle-stop tour of the campaign and what we're trying to do and why, but very happy to take questions if we have time, and looking forward to talking more in the chat later.
Thank you very much, Grace. That was really interesting and nicely followed on from Kym's talk as well. So lovely. So you've got loads of positive comments on the side already. I'm mindful for time, and I'm mindful that we will have a breakout room later on where Grace and Kym will both be talking with you about music and dementia and how that can be used. So we've got time for one quick question. So Jess was saying, her mum is from the Windrush generation. We put on 50s music, but quickly realised she didn't relate as her home in the 50s was Caribbean. Any chance of BAME sounds? She loves 60s as she was in the UK then.
Yeah, is this for the radio station? Yeah, we are currently looking at how we can keep continuing developing our programming. So I can take that back to the team, and we can build some of that content in.
Great, yes, lovely. So thank you so much, Grace. We'll see you later in the breakout rooms again. So
thank you.
Thank you. And now we've got, again, a very different talk from Dr. Masoud Isanejad. And he will be talking, on frailty and aging. So, Masoud, over to you.
Okay, it's really a big joy to be here today. Hello, everyone, and especially thank to Clarissa that organized this fantastic workshop/seminar. Very great presentation. So, I'm a tenure-track fellow lecturer from University of Liverpool with a wide interest into healthy aging and especially frailty in older people. So, in narrating this story today, I decided to have a very broad view on frailty, give some summary about it. And if I can share, okay. So my general discussion points would be on understanding what is frailty, its crosstalk with dementia, and if there is a way out of that. So we have managed very well within the past decades to live longer and exceed the expectation, but that came with the consequences. We all are familiar with this famous sentence that what doesn't kill you make you stronger, which is not making sense anymore in field of aging and getting older, because most of the diseases which we are dealing with, as it published by the Green Paper from the UK government, are musculoskeletal disorder, mental disorder, and neurological disorder, which interestingly, they're all integrated very highly with frailty and dementia. And really these issues not just are making you stronger, but making you actually suffer more. So if I want to really talk about what is frailty, there are several debates, scientific debate, international organization, trying to come up with a unified consensus and definition for frailty. However, we don't have yet a certain diagnosis method or a unified definition, but the very common phenomenon and dimensions that all the frailty definitions are sharing together is that frailty is a multidimensional and a physical and psychological issue, is an extreme consequence of the normal aging process, and is dynamic. So one person can really fluctuate from the status of frailty, from being pre-frail, non-frail, to frail, even within the short time, for example, during hospitalization or among the community living older people. I cannot just skip without going forward by mentioning the dominant definitions of frailty just to bear that in mind for those of you who are interested to follow this forward. One is developed by Fried and his colleague in 2001, which focuses on 5 different dimensions of frailty, a mix of physical function tests and mental well-being tests. And the other one by Rockwood and Minsky, where they come up with the frailty index score, is a summary of many questions on health, symptoms, disabilities, diseases, and so on. So it's really not relevant to talk about this in details, but I just wanted to mention that there are several definitions to frailty, and that make it more confusing, especially when we talk about the prevalence of frailty. As a summary, the prevalence of frailty is almost equal to Alzheimer's prevalence, with being about 10% of our population age 65 years above involved with the frailty and dementia, 20 to 30% when we are looking at the population age 75 above, and 40% in the population of age 90 years and above. And this has been published in 2012 by Collard and colleague. So why we do care about frailty and what is it about? So as you can see, I just put here maybe the top consequences, the negative consequences of frailty for our health, which is increasing the risk of hospitalization and getting recovered after being admitted to hospital, increase the number of nursing home admissions. So these two are significant to our health individually and also adds a lot of burden to the healthcare system worldwide. It's associated with cognitive decline. It reduces our quality of life. The loneliness and frailty have been correlated frequently in the literature. Affects our mobility to take care of our daily activity, the tasks that we have every day, and increase the number of fall and fracture. And of course, expectedly, is highly associated with dementia, which is the focus of today's seminar as well. So there are a lot of mechanisms involved. It's out of the scope of our discussion today, but I just wanted to show you this very interesting graph, which shows that cognitive frailty, the risk of cognitive frailty, have been correlated frequently in the literature with different parts of our body. So cardiovascular diseases increase the risk of cognitive frailty, depression as a mental disorder, the blood biomarkers, the inflammation in our body, the type of lipid profiles in our blood, and so on, as well as the muscle health. So one may ask if actually cognitive frailty and dementia are the same, and this goes back maybe to the exhaustive talk that how we should define dementia and frailty, but that should not hold us back. Probably the lesson to learn here is that they are sharing the same symptoms, and dementia, by being characterized of a progressive decline in cognitive and ability to perform activity, actually is part of the cognitive frailty and how we define frailty. So moving forward from that, is just a UK Biobank published one very interesting study very recently in Lancet in 2020, a couple of months before, which shows that the status of frailty, including pre-frailty and frailty, is associated with increased risk of dementia in about 144,000 participants from the UK Biobank. And that gives us very good, clear picture that even after adjusting and controlling for many different factors, frailty can be an independent predictor of dementia. So if we come up with a model where we can find the people who are suffering from frailty or they are pre-frail, probably to large extent, we can prevent dementia as well. And this has a lot of implication for our clinical practice and GPs and our healthcare system in NHS. So this has been raised as an issue. And in 2017, the NHS England started a mission to really improve and increase the capacity of screening people for frailty. So today, the GPs are asked to screen and control for for symptoms of frailty, especially when the patients age 65 years above are admitted or visiting their GPs, and then the guidelines are available. How good we are doing this now is a question, but the fact that it's part of our health protocol now shows the importance of screening for frailty. And it's not really a complicated task. Every person, every family member, those who are taking care of the older people or the adults themselves can really run this really simple test to see what is their status, which I think is a discussion for the workshop, the continue chat that we will have in the breakout room. So I also like to mention that we talked about the mechanism and frailty and dementia and how they're associated with each other. But what is really the onset of the risk factors that they increase the risk of onset of frailty and dementia, and the lifestyle risk factors are poor diet, sedentary lifestyle, and obesity, which we all are familiar with, which have been repeatedly mentioned to be correlated with different diseases and negative health outcomes, and is not very different when we talk about frailty. But the good news is that we know both frailty and dementia are preventable. And actually, in 2020, a report was published finding different major risk factors in accurately, actually 12 risk factors for dementia. And they mentioned that all these risk factors are modifiable, which translates basically that we can prevent it. And 40% of it actually could be delayed. So, and frailty was one of these 12, and a major part of this, one of these 12 risk factors, which was associated with dementia, which takes us back again to this graph. And I just want to now replace frailty with diet and physical activity here. So when we look at the problem in this way, we realize that most of these issues can be treated or delayed and either prevented if we follow the diet and physical activity, whether as a long-term habitual intervention or looking at it in a short-term interventions for our older people. In a very short time, I will also relate this again to the music and the really fascinating intervention that other presenters talked about. And again, I take you back to this complicated slide with a lot of mechanism involved to frailty. And when I put again here diet and lifestyle, you can see that most of these factors are again correlated with what we eat and what we do in the daily life. So the CVDs, sarcopenia, muscle mass loss, muscle strength loss, the blood profile, gut microbiota, and many other mechanisms involved with cognitive frailty and dementia are actually correlated with our diet and lifestyle. So it's really not far from thinking that by really small modification in our life, we can prevent these things to a large extent. And the question now is how? So there are tons of different guidelines, interventions out there published on intervention for frailty, but the maybe most frequent and the highest evidence is available that following a sort of Mediterranean diet pyramid, which I put here for you, it's maybe one of the best dietary intervention that we can have. So very shortly, is a lot of focus on grains, seeds, beans, and fruits and vegetables. And then there is protein and seafoods. So as the really important part of protein intake, the focus on is seafood, and less focus on red meat, poultry, cheese, and dairy products. So it's really thinking about our diet and trying to modify that. So as much as we can, we adhere to this pyramid, plus, again, music, dancing, physical activity, don't forgetting the joy of life, and eating together. So these are probably as a very good summary that how we can, to a very large extent, change our own life and our surrounding. And talking about how much physical activity is needed, So there are a lot of focus on intervention, exercise intervention, strength training. Of course, they're useful. But I wanted to mention that even a small amount of physical activity have been shown to be very effective to improve the physical capacity in older people. So examples such as 10 minutes walking a day, or 7.5 minutes intensive physical activity a day, or increasing the number of steps per day for 5,000, have been shown that it has even long-term effect in reducing the risk of losing physical capacity. So really is about doing something every day and not thinking that physical activity means that to take part in classes or go to gym, which are of course great, but really to dance and to do things that we like every day, to have a walk with our friend and doing those things that we love can really change who we are mentally and physically. So I hope that you could enjoy a bit my long conversation, but I'm happy to take questions now. And thank you for listening and inviting me for this event today.
Thank you very much, Masoud. That was great and positive as well. So something can be done, isn't it? Oh, I think you've got another slide there shared.
Okay, sorry.
So quite positive, isn't it? So that everyone can do something about it.
Yes, that's true. So to a large extent, we know that is actually with enough scientific evidence that most of these unfortunate consequences are preventable. And even those who are suffering it from now can to a large extent get better. So it is about changing our diet and physical activity habits. So, yep.
Yeah, we're not moving on yet to you, Asan. We've still got some time for questions for Masoud. So is there any other questions? Also, just to raise awareness, we will have a breakout room later as well, where Masoud and Asan will both be talking with you about multimorbidity and aging. Yeah.
Yes.
Yeah, Jack has just typed here, as a 69-year-old who is primary carer for a 95-year-old, I found this very encouraging. Thank you, Masoud. And Ginger's also highlighting again that your focus on the diet elements of the Mediterranean diet and how that's important to everyday life. Yes. Okay, so unless there's any more questions, thank you very much, Masoud. That was good. Thank you. And now, so just before I hand over to Asan, I know it's been quite a few talks already, lots of different information. So we will have a 15-minute break at 12 o'clock. And then afterwards, we will have a couple more talks on specifically COVID, care and dementia. And then we will have the breakout rooms. So now we have around 10 minutes for Asan, who will be talking on what matters to older people. Okay, over to you, Asan.
Okay, thank you very much. And it's a delight to be here at the conference, and I've really enjoyed the sessions that have gone on beforehand. I'm a community geriatrician, so I'm a medical doctor that specializes in the care of older people, and I work both in the hospital and outside. That has changed recently, obviously with the COVID, and I'm doing more of remote working at the moment. Struggling to move my slides. I'm struggling to move my slides. It's not following my command. I don't know if Carl or anyone can give me some advice what to do.
Is it possible maybe to just give the talk on that one slide then maybe, Asan?
Yes, of course, yes. So I'll stop sharing and then I'll just talk to my slides if that's okay.
Oh no, please keep the shared slide on. Just talk to that one slide.
Okay. I just need to have a look at my slides, Clarissa. That's the problem I have. I'm sorry, I'll soon get there now.
Clarissa, if you have Asan's slide, maybe you could do it on behalf.
I don't, I'm afraid. Sorry.
That's all right, don't worry. I'll just talk to the slides because it's straightforward and
Thanks for bearing with us. That's technology 2020.
okay, so my apologies. So I'll carry on. A few years ago in Newcastle, a lot of older people were brought together to talk about what were of concerns to them, or what were the challenges that they faced when they grew older. And I'll try and put this slide back again so that you can actually see what people thought mattered to them. Okay, so sorry, again, I can't do that. So I'll just have to speak to my slide. I don't know what's happening. Now, the things that I'm going to mention are not going to surprise you, but it's the reason I'm mentioning it is that it's important to keep in mind when we're engaging with older people, whether as clinicians, whether as researchers, whether as friends, that these are some of the challenges that they face and we will face when we do get older. So there were things and challenges with walking, mobility, and balance. People mentioned that they were feeling very tired and fatigued. People complained about joint pain, various joints, back pain. People complained about bladder problems, so all sorts of bladder problems, hearing, problems with vision, dexterity, so the ability to open things, to button up, so anything that required manual handling, people were beginning to have challenges with that. Problems with bowels, problems with the memory, and today we've heard a lot about various aspects of cognitive impairment, especially dementia, and also social life. So when we forget that when we get older, things happen. We lose friends, friends move to other places, friends die. Our spouses or our partners get ill and die. People get divorced. So life does change when we do get older. And these were the things that people found that were of importance to them, that really mattered to them. And sometimes when we speak to older people or when we do research with them, we might approach them with things that are on our own agenda, which is good, but I think it's also equally important maybe to ask questions about these other points that I have made, which is about mobility, fatigue, pain, bladder and bowel problems, vision and hearing, dexterity, memory, and social life. And I'll give my slides to Clarissa so that you can all have access to them later with the links to where this work was done. On the other hand, a lot of research driven by professionals, both clinicians and researchers, has focused on exercise therapy, falls, psychological well-being, carer well-being, frailty, polypharmacy, coordination of care, and social epidemiology. And while these are important and are linked to some of the things I mentioned, it is not too difficult to actually incorporate what matters to older people, what is of importance to them, to whatever our research or clinical agenda might be. It probably doesn't take much to try and incorporate that. Now, why is that important? It is important because if we only focus on what matters to us as clinicians or researchers, we will of course tick the box for ourselves, but we will not be addressing what matters to older people in a rich and meaningful and deep way. And this is the opportunity to align our own agenda with that of older people. And let's also remember that older people tend to be classed as a homogeneous group. So once you're, depending on what age cutoff people use, in this country, we tend to use 65, but people refer to older people 65 to 100 as if they are all the same. If I said to you, oh, from age 1 to 60, that's one group, they are all the same, they should all be treated the same, you'll probably crucify me. But we don't usually think much about saying, oh, older people, and we sort of stereotype and think that they are one homogeneous group. Someone who is 60 is very different from someone who is 90, and someone very different from someone who is 100. They are very, very different. So we also need to keep that in mind when we are interacting with older people, and actually see them as an individual, as a person, and try and make sure that we understand what really matters to them. I do spend a lot of time working with different clinical groups, and also when we're working with research groups. And one of the top questions I always ask, usually in the first 5 minutes, is I said, where are the people that you're going to be working with? Where are they in this room? Because if they are not in this room, if they are not having this conversation, then it's very unlikely that the outcome of our clinical work or our research is going to be meaningful to that group. So that's another strand to my work. I engage a lot with groups of older people. I'm very fortunate that I have links to various networks across Sefton and Liverpool. And for those that work with me, I always try and introduce them early on so that their research ideas or their service development ideas can be shared in that group and discussed, because usually we then get very meaningful feedback, which makes our outcomes that much better. I am sorry that I've not been able to share the slide, but this happens to me from time to time. But the slides will be emailed to you. It's got all my contact details, and I'm happy for people to email me and ask for anything, and I'm happy to help. Thank you.
Thank you very much, Asan. Okay, so just a comment from Jenny. She's just posted, it's great to hear the voice of older people and view the world from their perspective. We need to work harder to include older people and more specifically explore ways of connecting with people with dementia to bring into this research. So she was just saying, thanks for reminding of this. Okay. So both Asan and Masoud will be leading the breakout room later on. Asan, you've just started sharing your screen again.
No, I just put that up. That's the most important slide, so people can still have a look at it before they go.
Okay, so both Asan and Masoud will be leading the breakout room later on multimorbidity and aging. And so thank you, Asan, for sharing some of your work despite technical difficulties. That's great. So I'm mindful we've all had about 2 hours now of lots of different talks. Asan, if you could unshare your screen, please. So that's been really interesting. We heard from loads of different providers and different research topics. So I hope it's given you lots of new thoughts, lots of ideas already. And now I think it's time to have a little bit of a comfort break for 15 minutes approximately. And we'll be back at 12:15. So I hope you'll all be still with us then, and we'll have 3 more talks lined up on COVID-19 and care, including we will hear from Paul Marlow, who's been caring for his mother living with dementia. Okay, so far, thank you very much for joining us. Okay, I'll see you very soon. Right, hi everyone again. Hope everyone had a little break. It's 12:15 now. So we've got an hour of a couple of COVID and care talks. And first of all, I'd like to welcome Paul Marlow, who is a carer for his mother living with dementia. And he will be talking about his caring experiences during COVID. And I know that Debbie, you are sharing his slides. So welcome, Paul. Nice to have you here.
Thank you.
So I think Debbie will share your slides in a second, I hope. Or Cal. Oh, there we go. Over to you, Paul.
Okay, thank you. Well, thank you to Clarissa and to everybody. I've enjoyed everyone's presentations this morning. And it's a bit of a privilege really to be able to share my own lockdown story and the experiences of me and my mum during the pandemic. Millions of us have obviously have our stories, and carers have often been invisible, I think, and it's kind of it is a privilege to be able to share my story. I've got 3 slides, which obviously Debbie is going to help me with, and they're just photographs really of pictures of my mum before, during, and after the lockdown. My mum's name is Margaret, and as you can see on that slide there, my mum and dad in 2013. I've been a carer for basically about 7 years. And my mum is 87. She's from Liverpool. She was a school secretary, and she was married to Jim, and he died in 2017, and I had 3 children. My impression of my mum growing up was that she always put people first. That was always her motivation, and I just felt as a carer, I'd like to do anything in my power to keep my parents at home. My parents lived with me, and after my dad had a stroke, I looked after him, and obviously I looked after my mum, and she was diagnosed in 2017. I feel that like before the lockdown, we were almost in a sort of unofficial lockdown anyway as a carer, and you know the move from like the pre-lockdown into lockdown was obviously quite significant, but I think because I've been a carer for some time, and I'm sure lots of other carers feel the same, that there wasn't sometimes like a massive step between the 2 experiences. For my mum, it was very difficult, I think, for her to accept that anything was wrong in terms of her health. And before the lockdown, we had the care package involved us having one visit a day, and then my mum went to a day centre 3 days a week. And we also, as some of those pictures demonstrate, we were very, very active. I took my mum out as much as possible. We went on a holiday. We went out in the car all the time, and I mean, we did have a very, very active lifestyle. And before lockdown happened, I did feel there was a sense that life was becoming a bit unsustainable as a carer with the advances in my mum's condition. So prior to the actual lockdown, that when Boris Johnson announced the lockdown, my mum had to have she went into for an outpatient appointment in the Women's Hospital, and that was the weekend before the lockdown, and I was that was probably possibly one of the most anxious periods of the whole experience, because it was all new. It was new to us all, and I felt that mum might contract COVID if she went into this hospital, or we might take it in with us. And it was quite a stressful time, really, that weekend before the lockdown commenced. When we came out, the couple of days after the hospital visit, we were told that someone from the day centre had possibly been in contact with someone who tested positive. And as a result of this, I contacted the doctor and we were told to self-isolate for 2 weeks. So basically, all the care we had basically went overnight. We had 29 hours of care, which included the 3 visits to the day centre. And we also had a care package. So for 2 weeks, we went down from 29 hours to no help at all. My family would help with buying food, and obviously would leave it outside. And I would take it in, but all the care, all the personal care, everything had to be done by myself. And obviously that was quite a demanding 2 weeks. One of the big things for me was about concerns was the reintroduction of care after the 2 weeks. And obviously there was what the priority was mum's safety, but there was also like my own ability and my own sort of mental health and being able to cope with this, with the care under these conditions. So I did reintroduce the care after the 2 weeks, but you know, there was a bit of inconsistency I felt in the use of PPE by the carers, but obviously I had to have people back in. In terms of like our day-to-day life, I found routine was very important, both for myself and for my mum. And there were certain things that would help. For example, I'm sure you all remember how lovely the weather was in sort of springtime. And spring obviously is a lovely season anyway. And this year, thankfully, the weather was fantastic, and we were able to go out in the garden. We were very lucky to have the garden. Debbie, if you could do the next slide, please. So here's some images of during the lockdown, and as you can see, mum was in the garden on one of the slides, and we used to sit in the back garden quite a lot. We also found that I also discovered that we went into the hall quite a lot because the sun kind of comes in the garden into the house at the front during the daytime and in the afternoon. So this is my mum having a piece of cake on one of the seats in the hall. And it's quite unusual to think that, you know, the hall became such an important part of our lives, because we sit outside, and I'd sit in the porch and my mum would sit on the chair, and that was a really good sort of routine. In terms of myself, I mean, I had a sort of exercise program. I went to the gym quite a lot before it, so I tried to maintain that, obviously in the house. And quite a few speakers this morning have talked about music. Music was absolutely essential to my mum and you know, in our experience. And I did actually write a blog for Tide, and that ended up appearing in the Liverpool Echo. And you can see I've put a slide there, a photograph there of a photograph of the newspaper article. And you know, Andy Williams in particular, that moment was very important. And you know, we used to have some dancers in the lounge, and also my mum sort of increasingly she used sort of hand movements to go along with the music, and she expressed herself in that way. So I think music was extremely important in connecting mum with the past. And it was almost like a flick of a switch, and her personality would change and her condition would improve greatly. So I found music, dancing was very important. I think as time went on during the lockdown, I think there were changes to my mum's sort of. There was a deterioration really in my mum. As you can see from the first slide, there was we went out quite a lot. So obviously we couldn't go out during the lockdown. And my mum's mobility worsened, even though obviously I tried to keep her dancing and moving around the house and so on. But also I found that she was becoming, there was a lot more like screaming, just in movements, and she'd get very distressed when she was moving around the house. And I did have quite a lot of input from like medical professionals, and we had people come into the house like physios, and they couldn't sort of see anything that was particularly like physically wrong. I just feel maybe it was just to do with an advancement of the condition, which meant she became more distressed and moving around the house. So that was something which concerned me quite a lot. The fact that her mobility and her sort of, you know, her sort of cognitive ability sort of deteriorated, which was terrible to see, really, because obviously I tried to always keep her motivated and active as much as possible. I did have a lot of input, I think, from things like an Admiral nurse, work with the British Legion, through phone calls. I also had a few conversations with like Clarissa on the phone, like surveys. Tide kind of contacted me, the carers centre. I did have a carers assessment. So I think because I'd built up quite a lot of professional contacts over the years of caring, I think I had quite a good sort of foundation to build upon. And I do think the input from those professional services, the caring services, was very good, actually. One thing that did get to me a little bit was the fact that I felt that the government were quite slow to say have carers become key workers, and that sort of that annoyed me a little bit, because I felt that obviously the role of carers is absolutely fantastic in society. One thing which is interesting as well, like, you know, despite all this, like, you know, obviously we're surrounded by COVID and surrounded by all the news. You know, all my day-to-day life was completely dominated by what was happening because of COVID. But at the same time, my mum was completely oblivious to it, and I had to sort of protect her a little bit from it. And any talk about the virus, and she would get kind of distressed. I think we had a new care plan come into operation, which increased the number of visits to 4 visits a day. I had a very good involvement with a new social worker, and there was a number of instances where I felt I was getting to the situation where I possibly wasn't able to kind of cope in the house for much longer. And as lockdown started to ease, it was a case of like, what now? How is this going to be sustainable in the future? Because I couldn't seem to get like longer periods of care coming into the house. I did use carers vouchers prior to the lockdown, and the lady who was caring, she had to shield herself, and so that wasn't coming back. So I felt coming out of lockdown in some ways was quite difficult, and I really did feel as if like the situation was becoming out of control, really. I felt I was on a situation where I was leading to like a carer breakdown. So one thing was that after lockdown, when the restrictions eased, I found it very difficult to get mum in the car, and I thought that was really going to limit what mum could do and what we could do. For example, when the day centre came back, my mum did go into in July. My mum went into respite, and when she was in respite, you know, I kind of decided with my family that it was possibly better to make it into a permanent position. The next slide, Debbie. This is my mum in the care home. Now, obviously, there's obviously like a lot of restrictions at the moment, and you know, hopefully we will be able to see her. I haven't seen her since September. You know, I haven't been to the care home since September. I do feel a lot of guilt, really, about what happened. You know, I feel like I really wanted my belief was to keep her mum at home as best I could, and I just feel that rationally, I know it was becoming very difficult to do that, and her best interest was served by being in a care home. You know, I think for myself, I think, you know, I think for myself, looking after my parents, caring for my mum, and for my dad, you know, it was probably like some of the most sort of defining experiences of my life, really. And you know, I think I've got a lot of kind of memories, and I just did the best I could, really, to keep my mum at home. But you know, I just think, you know, anybody who looks after anybody in a caring role, you know, needs support, really. And I think you know, caring is I think caring with the pandemic, I think caring and care homes, the whole area of care has been pushed into the sort of the sort of the news, and I think that's really important, that, you know, carers are given the support to be able to look after their parents. But so thank you for listening, and you know, I've really enjoyed listening to everyone's talks today. Thank you.
Thank you so much, Paul. Thanks for sharing this so openly and honestly. I mean, we're working together on some of our dementia work, so I know your story a little bit, but I'm sure everyone is agreeing that it's lovely to hear from someone who's been living through it. And it sounds like it was really difficult, the COVID time, wasn't it?
Yeah. Yeah, I mean, I would guess as well, for the coming out of the lockdown was very problematic for a lot of carers, and remains a lot of problematic, you know, in terms of care coming back to help them. Yeah,
and you've got some very nice comments on the side as well, and I know there's some carers here joining us today as well. So everyone's saying thank you for sharing your thoughts, Paul, and your experiences. So
okay, thank you.
Great. And just picking up a comment from Jane, she's saying you did an amazing job, Paul. Both my parents have ended up in care this year during lockdown, and I know how hard it is not seeing them, but know they're safe. Well done. So yeah, I would encourage you to have a look at the chat box, Paul. Lots of positive comments pouring in. So that's nice to hear. And also to make everyone aware, there will be a breakout room later with Paul and with Warren Donnellan hosting this on COVID and care. So if you have any more specific thoughts or want to have a chat with Paul about it, please join that room. Okay. Well, thank you, Paul.
Thank you to Debbie for sharing the slides.
Yes. Okay, so now I'm going to give a quick insight into one of our COVID dementia projects, and awkward slide sharing moment again. Here we go. Okay, so I hope everyone can see that now. To a large screen. Oh, there we go. Okay, so some of you might have seen a webinar a couple of months ago, back in September, where I've been talking about COVID-19 and our study on how public health measures have impacted on social care and social service provision in dementia and aging. So now I'm going to give a quick updated overview of this. So I'm sure many of you, or if not all of you, are familiar with the kind of statistics behind it. In the UK, we have over 850,000 people living with dementia at the moment. It's more closer to 1 million now. And picking up on what other speakers were saying earlier, really the importance of family or unpaid carers. They contribute over £13 billion worth of care each year by doing personal care tasks with their loved ones, by providing meals, dressing, or just providing an activity for them. And it's really important to highlight how much they need support in their own right. And I think that particularly came out during the COVID pandemic now as well, how much more support they need, as opposed to only the person living with dementia. So what we did in our study, we looked at how COVID public health measures have impacted on social support services for dementia. When we talk about social support services, we're looking at all types of stuff, including paid home carers coming into your home, befrienders coming into your home, peer support groups, daycare centres, respite care, something like Kym was talking about earlier, like singing and dancing groups or hobby groups, all these different types of support services. Now, as you can see in the pictures, and as many of you will know, these are all face-to-face. So given the public health measures and suggesting, well, first of all, we had the 3 months lockdown, so no face-to-face should occur. How we were wondering, how does this impact on the lives of both people with dementia and carers very early on in the pandemic? So what we did was back in April, so starting the first week of April, we did telephone interviews with people living with dementia and with unpaid carers. We really want 50 interviews we did in total across the UK. And we really wanted to understand what types of services have you been using before the pandemic, and how has the pandemic now affected it? Are you still accessing them? Are you accessing them remotely? Why are you not accessing them? And then a few months later, we did a subsample of follow-up interviews. So we interviewed 20 people later on in June and July to understand, has anything changed? Has the service provision hopefully improved now? So I'm going to talk a little bit about some of our early findings of this qualitative study. So bearing in mind this was April, we conducted all the baseline interviews in April. And already then, people were noticing a much faster deterioration of the person living with dementia. So as you see here on the screen, the bottom quote, 5 weeks ago, my dad was a totally different person than he is now. He probably won't come back from this. So we can kind of see that this lack of social interaction, the lack of stimulation, going outside, seeing other people, talking to other people, or as Masoud was saying as well, not being physically active, being restricted to your home due to the lockdown measures, that resulted in carers who are seeing their loved ones with dementia every day already noticing he or she has deteriorated much more since the lockdown. And people were just worried that how long will this go on? So there was this huge level of uncertainty in terms of, well, when will services be up and running again? Will they be up and running again, and how? So would they be running with smaller numbers of people there, people wearing face? I mean, this was April. We now know the story a little bit better, and that some support groups have started to open again in the summer before the second wave. But this was really at the height of the first wave, and there was a lot of emotional uncertainty and lots of anxiety and stresses in the people living with dementia and the carers. So there's this uncertainty surrounding support provision. But already there was this adapting to the new normal. And as you've seen today, even we kind of know how to use technology, but even we can sometimes have some technical glitches. That just happens, that's normal. But now just imagine we have an often elderly person who has cognitive deficits, who has dementia. They're less likely to understand how to use Zoom, how to use WhatsApp groups maybe as well, Skype. And then there's the added difficulty of some people with different subtypes of dementia. For example, posterior cortical atrophy. These people with dementia have specific vision issues. So they will really struggle seeing a screen full of participants on the Zoom chat, but they won't be able to recognize them. And also, remote support is just not the same as face-to-face support. So everyone was saying, well, remote support is somehow helpful if we do get it, and many people didn't get anything. But even if they did get it, it didn't provide them with the same level of support and didn't enrich their life as much. So one particular angle we looked at in terms of social support services was understanding how paid home care is being delivered during the pandemic. Again, that was in April, the experiences, and now we know there's guidance in place in terms of how paid home care staff should deliver care in the home environment. But back then, everything was new, and there were loads of varied experiences as well. So as you can see on the left side, there's an image of a carer who's almost hugging the lady. that was pre-pandemic. We didn't have to worry about distance, transmission of the virus. And then on the right side, how things have changed. So care staff is supposed to wear the full level of PPE, so glove, visor, face mask, apron. And here you see the carer dressing the elderly gentleman. But on the whole, there should be always the 2-meter distance maintained, unless it's a personal care task. So what we wanted to understand is, how did carers, so family carers, unpaid carers, decide on whether or not to continue receiving paid home carers into the home, considering this increased risk of virus transmission? So we had 15 unpaid carers who had experiences of receiving paid home care before the pandemic. And there was a mix of decisions. Many people were strictly against receiving any strangers into the home. They were too afraid of possible virus transmission, so they thought, okay, I'm going to stop this now. I don't want my mother or my husband to get infected by the virus possibly, so they cancelled the care. But as a result of that, these unpaid carers or family carers got overburdened, because they had to pick up all these additional caring duties that usually paid members of staff would do. So some of the families decided, no, we just can't cope without any additional support, so we need to have these paid carers coming in. There was also a lot of different experiences surrounding PPE back then. So some paid staff didn't wear any PPE at all. And actually we've spoken to some families, and they were actively, what's the word for it? Complaining about it, saying, I don't want you to come back unless you're wearing the full PPE. So some were taking a very proactive stance. But other paid carers had just gloves, others just face masks, others the full set. So really different experiences. But what it really shows is that there's difficult decisions, and really difficult decisions being made as to whether to continue receiving care or not. So that was a bit of a snapshot on our qualitative work that we've done. We're currently still finalizing the follow-up interviews. And what we've noticed in the follow-up interviews is that things have changed a little bit to the better. Back in June, July, services were better adapted to providing remote support, but still a lot of things needed to change. So we did a complementary piece of work, which was a quantitative survey, as opposed to just talking to people about their experiences, which gives us a really rich information. We also wanted to quantify the experiences of people with dementia, carers, and older adults as well. So we did an online and telephone survey supported by the NIHR Joint Dementia Research, which was great to help us in recruiting participants. What we wanted to understand was precisely how many hours a week have people accessed social support services before the pandemic and since, and how has that impacted on their mental health and mental well-being. So at 3 different time points, both between April and May, between May and June, and then between July and August. And if we remember, at time point 3 then, lockdown was eased and shielding had stopped early August, so restrictions were eased. So we asked people about their levels of depression, levels of anxiety, levels of well-being, and we had in total around 400 people who've completed all 3 time points. And we've had some great support by third sector organizations, including the Brain Charity, including many other charities, including the Lewy Body Society, helping us with recruiting participants for this. As you can see here, we have had complete data for 377 people. So that includes people with dementia, current and former carers, because we didn't want to exclude former carers. We know that former carers who have cared for someone in the past, many of them still like to access peer support groups, for example. And we've also included older adults. As you can see on the left side in the figure, you can see the level, well, the proportion of people who have been accessing different types of support services. And we've selected those that were most accessed out of a list of about 12 or 13. On the left side, you can see paid carers. And as you can see, actually, whilst paid care has gone down at time point 1, so just lockdown 1, it's actually started to increase again during those 3 time points. And as you can see, if you compare it across support groups, daycare, befrienders, and social activities, paid carers, the proportion of people who have been using paid carers, has stayed the highest. So it's been the least affected. Whereas people using support groups or daycare or befriender services, that's completely declined since lockdown 1 and kind of stayed that way as well. On the right side, you can see this specifically based on groups. So we have separately looked at people with dementia, current carers, former carers, and older adults, and just to see how many types of services, well, whether they have accessed any services. And it seems like current carers have accessed the majority of services. You can see here around 85% before the pandemic, but then it dropped. But as you can see throughout, it seems to have increased very slightly from time point 1 to time point 3, which is encouraging because it shows that services have adapted to providing some level of remote support. So this is just a kind of overview of how social support services have been affected in those first few months of the pandemic. But what we wanted to understand is, well, how is it linked to mental health and mental well-being? Now, we kind of knew before the pandemic, engaging in social activities is important. But I think what COVID has shown us even more is that, well, suddenly all that support is ripped out from underneath you. And it really showed that not having that access to social support services was linked to higher levels of anxiety in people living with dementia and in older adults. We've also found that not having this social support anymore was linked to reduced levels of mental well-being in unpaid carers and in older adults. So there's a clear link between how the public health measures have impacted on the mental well-being and mental health people with dementia, carers, and older people. So some of those implications so far, just a brief summary, but we know that research is always going on and everything's in the news and on care homes at the moment as well. But what we can summarize so far is that remote support does help, but it's just not the same. So whilst we need to be mindful of the different tiers that we're in as of tomorrow and the different lockdowns, face-to-face support, at least in the summer it was possible, should be enabled where possible. But this really depends on the individual and their perceptions and their risk assessments and how this would be enabled, in what type of group setting, how safe it would be. And also what we found is that there really needs to be better support for older people and people with dementia to engage with digital technology in order to access these remote types of support services better and not be left out. And also just to highlight, we are currently comparing this internationally. So we've done the same types of interviews in Australia, Italy, Poland, and India to have an understanding, and we've got the first data, and what we can already bring out of them is that, well, people seem to have the same issues everywhere so far. So in terms of accessing services, how it impacts on their lives, but we will share this in due course. And lastly, just to say a really, really big thank you to everyone who's taken part, but also to all the different organizations who've made this possible. It wouldn't have been easy otherwise. And yes, and also to the carers and a person with dementia who was joining our research team. So thank you. Okay, stop sharing. Okay, now, if there are any questions, I'm just going to pick them up now, so sorry I couldn't read them throughout. So Andy is saying, are carers feeling comfortable to attend support groups in person? I know those we support have been hesitant and have opted mostly to attend on the phone. So I work with a number of different support group providers, and I think a few of them are on here as well. I'm referring to Hillary here particularly. And I know that some of them have started to put them in place in summer, but then soon after new restrictions came along. So I suppose it depends. Jack, did you pick up any evidence of difficulties relating to the use of masks by carers? Problems understanding their speech because their mouths were covered? We haven't in this study, but we've just finished data collection for a COVID care home study where we interviewed 42 family carers and care home staff, just analysing the data, and we did find that the masks are a huge barrier to relationships between care home staff and residents with dementia, but also when family carers are visiting their loved one with dementia and only seeing them through a pod, through a glass, and then having the face mask on because, well, they can't hear and can't see the mouth moving. So I will be in a different breakout room later, but if you have any more questions, please drop me an email. So thanks for listening to me. And now we've got a final talk before we can all talk in the breakout rooms. So we've got Warren joining us, Warren Donnellan from University of Liverpool, with a Christmas tree behind him, very festive. No Christmas jumper though, sadly. Okay. So Warren will be talking on his work on COVID and caring during lockdown, challenges and opportunities for digitally supporting carers. Over to you, Warren.
Thanks, Clarissa. I thought the Christmas jumper might have been a bit too much at this time of year. Okay, so let me try and share my screen. Okay. I'm not sure I've got the rights, Clarissa, if you can just give me the host rights.
You should have now.
Thank you very much. Okay. Excuse me a second. I do this, I teach students all the time. It took me 8 weeks to learn how to share screen properly. I'm still struggling. Excuse me. Excuse me a minute. Stop sharing. Just do that a little bit. Present a view. Cool. Let's try again. Portion of screen, share, and try present a view. Okay. Thanks for your patience, everyone. So can you see that okay? Presume. Let me know if you have any difficulty. Okay, so thanks again. So I feel really honoured to be here and quite a lot of pressure to follow such great talks. So I'm going to try my best to summarise a project that I've been working on with Dr. Matthew Lariviere in Sheffield in collaboration with Mobilise for the last few months, really, certainly looking at data starting during the first national lockdown. So it's essentially, we wrote an evaluation report looking at how digital technology can support informal carers during the COVID-19 pandemic, and I can share with you the report and a little sort of webinar that we did after the session if you're interested to find out more. Okay, so a bit about the context then around why we did this. So we know that about a third of adults reported giving help or support to someone they did not previously support before the pandemic. So we know many of the speakers so far have spoken about the significant increase in care being provided during this time. And a third of people also reported giving more help than prior to the pandemic. And Carers UK, in their Caring Behind Closed Doors report earlier this year, estimated that this number jumped from around 9.1 million total carers to about 13.6 million. And I always assume these things are a bit of an underestimate, if anything, because obviously not everyone's known to services. So a massive increase in the number of people providing care responsibilities, often for the first time. When we look at that caring behind closed doors report in a bit more detail, so we know that almost 2/3 of carers felt like they were unable to take breaks from caring during the initial pandemic period. About a quarter of people felt exhausted and worn out. Nearly a third of people had a sufficient support network, so not very many people at all. And nearly half of people felt unable to keep in contact with neighbours, families and friends. And I think we can all relate to a lot of this kind of social isolation and loneliness, but the problem is carers are already at risk. So this was compounding things quite a bit further. So what's the project about then? So we were working directly with a tech startup called Mobilise. And this is run by the co-founder James Townsend and his team. And it's a tech startup run by carers for carers. It's essentially an online peer support service. It's a community-driven business working directly with local authorities and carers centres to identify, engage and support carers with innovative technologies. So essentially, as the first national lockdown started, one of the big initiatives that Mobilise put in place was a series of daily virtual cuppers. So some of you here might have heard of these, but essentially the virtual cupper is facilitated by a professional carers coach, and they offer a relaxed online setting for carers to check in with other carers around the country and discuss the challenges that they face every day. So each cupper, it's a daily cupper, it lasts about half an hour, and that was a very deliberate decision, so it was quite compact. You know, not everyone has the time to commit to an hour-long thing. Variable times throughout the day, afternoon or evening. And essentially, these are the five key principles that Mobilise put in place. So peer support, the coming together of like-minded individuals who can share and provide their experiences. Coaching, so as it's been facilitated by a carers coach, there's a semi-structure there so that support can be provided when necessary. It's topical, so that what the beauty of doing it, and as you'll see the data that was elicited from this, is that it changes with on a daily basis depending on something that might have been in the news or daily issues that carers are having in that moment. Humour is a big characteristic as well. So they always say, it's okay to cry and share and be down and sad, but it's always important to end on an uplift. So they always try to end the cuppers on an uplift. And they were the key principles that Mobilise were trying to aim for. So where did we come in then? So again, together, myself and Matthew Lariviere at Sheffield, we partnered with Mobilise on a study that was funded by Aspect and the SRC and the University of Sheffield. And what we were really interested in, certainly myself as a psychologist, is using this rich data set provided by the cuppers, which I'll talk about in a minute, exactly how that became analysable data, to answer the four following questions. So the first one is, what are the challenges that carers are experiencing during this first national lockdown? What resources are they drawing on to manage and adapt to the challenges? How effective are the virtual cuppers themselves in reducing challenges and promoting resources? And then finally, what are the challenges associated with digital support and the virtual cupper peer support platform in particular? So what we did was, Mobilise were, as a part of their quality assurance procedures, recording their daily cuppers and they were transcribing them. So we were essentially given lots of qualitative data to look through. And this was daily data between the 20th of March and the 28th of July. So it's a huge period, really, really rich data source. So the data set corresponding to about 49 hours of cuppers, involving a total of 118 participating carers. And myself, Matthew, and our team of research assistants analysed the transcripts using thematic analysis, which essentially involves looking at it line by line and developing common themes across the daily data. And a subsample of the 118 people who took part filled in a little survey for us so we could find out a little bit more about them. I realise this might be a little bit small on your screen, so I'll try and break that down for you. So 30 people filled out the demographic questionnaire. So what we see here is that the majority of the CUPPA participants were between the age of 46 and 65. But there were some younger carers and there were some older carers as well. So you can see the 46 to 65 in blue and the 18 to 45 in dark blue and the 66 plus in green. The majority, in terms of ethnicity, that was, it's really important that we are representative, that we try to, boost and promote representativeness of the service provided. So Mobilise, the CUPPAs were attended by the majority of white carers, but there was a proportion of Asian and black carers as well. In terms of care duration, the majority had been providing care over a year, but interestingly, there was a proportion of people who'd not been caring for very long at all, in terms of 5 to 11 months. And in terms of care frequency at the bottom, the majority of people had, this was really interesting, perhaps the most standout finding is that people had reported providing a lot more care in terms of hours since the lockdown than before the lockdown. So we can't draw any statistically significant conclusions from this data, but it does reflect the trend of new people taking on carer roles and the increased frequency and intensity of the care work. Okay, so what I want to do for the majority of the talk then, it's always difficult presenting qualitative data, but Clarissa did a really good job of it, is give you a flavour of just some of the themes that were coming out according to each of those research questions. So for research question 1, what are the challenges that carers were facing using the CUPPA data, that daily CUPPA data? What were the key challenges during the first lockdown? So in the early stages of lockdown, so right back in March, and you can see I've put the date on here next to the quote. This is from the actual day that the quote came from, that the carer spoke. So carers experienced a great deal of uncertainty and anxiety in terms of what the lockdown would mean for them. And I know that's something that Paul described earlier on as well. So there's a lot of uncertainty and anxiety around what lockdown was going to mean for them and for their loved ones functioning as well. So this quote from someone on the 25th of March in that CUPPA describes, by the time all this is lifted, my fear is that my mum will have forgotten about me. It's a really powerful emotion there and driven by this sense of uncertainty. And then the other quote, so this really, I think, quite a nice analogy to describe how this carer feels. This was in April, so this was a month after. I feel as though I'm on a wave and you don't know where the wave is going to throw you next. I'm sort of bracing myself to see where we go. So again, it's, these carers have got enough on their plate, and because of government announcements and uncertainty, feeling as though they don't really know what's going on, which is a problem given the fact that they've got such an important role caring for the loved one. And the important thing to note here is that the theme of uncertainty carried all the way through the CUPPAs, from March right through to July. There was no less uncertainty. It was just that people were sort of managing it a little bit more easily. Okay. The other key challenge, and again, this list is not exhaustive, I've just tried to be selective, is social isolation and loneliness. So because of these government sanctioned measures such as social distancing, quarantine, shielding, many carers describe feeling like they're in a prison. The walls are closing in. That's how someone described it right back almost a few days after the first lockdown was announced. But then this carer here in May, so as late as May, it's a few months later on, described, it's about positive social interaction and affection and just craving a hug. And I think we've all been there. But this was particularly the case with carers who often felt very lonely. So it's interesting how both carers described being, closed in within the home environment. The key consequence of this isolation and loneliness was a desire for social interaction, which we'll talk about more when I present the resources. And then finally, fatigue, burden and burnout. So as you look towards the June and July period, I can barely remember now, it's all been a blur, but the cumulative effect of all of this uncertainty and social isolation was taking a really, really clear emotional toll on the carers taking part in the CUPPAs. Towards the end of the CUPPAs, there was a clear impact of 4 months worth of restrictions and increased caregiving responsibilities. So for example, on the 10th of June, couldn't figure out whether I was okay or just tired. And feels like the only thing that could make it better was to have more arms, more legs, more time, and more of me, which I just thought was a really powerful extract. And then right towards the very, very end of the cuppers that we looked at was this lady here saying that although he's not in my presence, her son, he still takes up an awful lot of my energy and my time, so my brain is fried. So real cumulative impact, and that had all kinds of consequences for things like demotivation and everything else. So essentially there's significant challenges being reported during the first COVID period, lack of information, social restrictions, and this had a clear emotional toll. But what I want to do in the next section is explore the various ways in which the carers managed and adapted to the challenges. So routine was important, it's been mentioned quite a bit today. So get back to a sense of routine gives us a sense of control. So re-establishing routine, new routines. So, morning swim, the cuppa itself became part of a routine. Having a semi-structure keeps us sane, as the person says on the 26th of March. Self-care is a really important part of that. Positivity and optimism, although that's a key characteristic and hallmark of the mobilised cuppas, it was a pre-existing quality of many of the carers who took part. So, not disregarding the darkness and the gloom and the negative, but trying to look for the light as much as possible. So although it's not a very real situation, it's not all doom and gloom, that taking part in the cuppas and sharing with like-minded friends and individuals made them feel like it wasn't all bad and that there was light at the end of the tunnel. And the research question 3 is coming to a close. So what is it about the cuppa itself that was promoting this? So it was about sharing information and resources. It was creating a forum within which people could share. So this quote from April, I always come out of these calls feeling very inspired, very energized, very motivated to do something. Sharing resources. So keywords like share, motivated, and feeling energized. So that was an important part of it. But also giving the people space for reflection and perspective. So I know people are trapped in their house a lot because of the virus, but this cuppa was the ideal opportunity to work with your partner to get things done. So by reflecting on the day in the cuppas with like-minded individuals, it often gave people the foresight to then go back re-energized to tackle challenges that they were facing. And then finally, because of the nature of the peer support, the cuppas became, a resource in their own right. It allowed both the provision of and the acquirement of tips, advice, guidance, emotional support with people who have things in common with them. And we know there's a whole wealth of literature on the power of peer support. And the research question 4, what were the challenges? So obviously, whenever you're doing anything using technology, as I can testify to, there are problems. So there were some problems accessing the cuppas. So there's a quote here from June. So Zoom wasn't working. She had to get a goddaughter to help her out and couldn't get any further, which is a direct barrier to this support intervention. There's all kinds of other issues around kind of internet connection, dropping out and whatnot. So it does rely on that. So that's a bit of a consideration. And then accepting technical problems. So part of it was just saying, technical problems will happen, but the carers on the calls were helping one another sort them out. And then where necessary, the carers coach was diversifying and getting in touch afterwards to make sure that they were ready for the next session as well. Okay. So in terms of what we found, and it was really, really quick summary, I realised, but I will provide the report in the chat afterwards, is essentially lack of information and social restrictions impacted certainty and control, which led to a cumulative impact of fatigue and burden over time. There was no denying that. But actually, looking at the data from these 118 carers were really quick to adapt and mitigate the challenges through the establishment of new routines and positive coping strategies. And what the cuppas did was they provided a forum within which carers could exchange information with each other and really develop proper lasting friendships as a result of that. And despite the occasional technical problems, the virtual cuppa supportive intervention did exceed its capacity and, as I said, became a resource in its own right to develop resilience. So I just want to end on a few recommendations. So really what this report calls for is additional investment in support per se. So regardless of whether it's analog or digital, there needs to be more specific carer support and more tailored support, which is something coming out of today's conference. In terms of technology itself, in the absence of any face-to-face interactions, we're not saying that digital is to replace. We're saying it can be used in conjunction and alongside to supplement face-to-face interaction. But we do need relevant investment in innovation and infrastructure around that to make sure people are connected. Digital literacy to make sure people are comfortable and confident using these platforms if they want to. And look into the future as well. What can we learn from the first lockdown ahead to future lockdowns, and indeed, God forbid, future public health crises like this one. So that's the end of my talk. I'd like to acknowledge our RAs, Lily, Sarah and Paige, and the mobilised carer community as well for sharing their experiences. Thank you very much.
Thank you very much, Warren. That was great, and also shows some overlap with our research, I suppose, on caring for dementia and COVID. So yeah, so if you want to share your report link as well, I'm sure many people are interested in it in the chat. Does anyone have any questions for Warren? I'm just looking, I haven't had any questions yet. No, but yeah, it's I suppose that digital technology issue is one of the main things as well, isn't it, Warren?
Yeah, it's a controversial topic. So, some people, and it's totally fine, people feel, not for me, and that's fine. But I think what it offers is an alternative. Well, not even an alternative. It offers a supplementary, complementary resource. And again, it's not for everyone. That's very much the message. But we know from the people who have taken part that it's been really powerful and a real lifeline during the lockdown.
Yeah, definitely. Getting some nice little comments on the chat box, so thank you. But yeah, there's certainly at Liverpool has been a lot of COVID and care research been going on, hasn't there? So ours is just a snapshot.
Absolutely, yeah. And the COPPers, I can share that. So the COPPers are continuing. I can share the Mobilise website as well, because they provide all kinds of support, not just the COPPers. They provide, a daily e-package, and they're constantly developing their services and building up their kind of network. So I'll share that as well.
Okay, thank you. So Warren and Paul will be leading one of the breakout rooms in a couple of minutes as well on COVID and care. And I think now, unless there are any more questions, I'm just going to share with you the information about those breakout rooms. So we will have 4 breakout rooms now for about half an hour. Room 1 will be how can we involve music in dementia care, and as we've heard some really fab talks earlier from Kym and Grace, they will be hosting that room. So you see below the link to the Zoom room. I'll explain in a second how we're going to sort this logistically. The second room will be looking at inequalities in receiving care. So if you're interested in that, myself and James Watson, we will be running this breakout discussion. So please stay in this room. The third room will be looking at COVID-19 and care. So as Warren was just giving his talk, and Paul will be joining him as well. And the fourth room will be hosted by Masoud and Asan on multimorbidity and aging. So how we're going to do this logistically, easiest, we thought it would be if you have a look now which room you want to join, click on the link below. They should be clickable, or just copy and paste into your web browser, please. If you want to have a discussion on inequalities in receiving care, just stay in this room. You don't need to do anything. And at the end of the half an hour, the hosts will be sharing the link to go back into this main room where we'll have a 15-minute joint discussion. So I hope that makes it understandable, but if I'm just looking at the chat now, okay. So Cal was just writing as well, we're not in room 2, just use the link. Okay, so please feel free to click away and join your breakout room, and we'll start our separate breakout room discussions in a couple of minutes. So Jack is just asking where's the link for room 4. It's just underneath the Zoom link. But what we can do, Cal, could you maybe share those links into the chat box? So room 1 is this. Sorry about this. I thought it would work on the slide. Oh dear. Okay, I'll stop sharing now and copy it this way. This is much easier. So room 3 here. And room 4 on multimorbidity and aging. Yes, so the main meeting link to come back to this room. Yes, Grace. So we'll just give it a few seconds to see who's leaving for other rooms. Okay, so I think we're just going to start. So thanks for staying with us. Feel free to click on your video now, so you can so we can see you, because we're going to have a proper little discussion now. So first of all, I'm just going to share a slide just to kind of give a bit of a background as to what we're going to talk about. So someone was asking what's room 2, inequalities and dementia care. So that's what we're going to talk about now. So just briefly, I'm going to share this screen with you and this slide. So we are now going to talk about inequalities in receiving care, inequalities in dementia care. And it's really, you've just heard a lot of talks, you've heard a lot of different people talking at you. Now we want to have this opportunity to have a chat with you and about your thoughts, about your experiences. And roughly, based on what James was talking about earlier on his systematic review on inequalities in dementia care, the dementia care pathways, what we're kind of interested in is to have a chat about the different barriers that people with dementia might face at all different stages of the pathways. So we're interested in the diagnosis or even pre-diagnosis, what happens afterwards, post-diagnostic care. So that's the social support groups, for example, that I was talking about earlier. And it's also long-term care, so care homes. And this is just to give us a backdrop. I'm going to stop sharing now. And yeah, just opening the floor, really. We're really just wanting to hear from you. Do you have any experiences? Do you want to share? And is this all confidential? Oh no, actually, sorry, it's recording. So if you don't want to say anything you don't want publicly on YouTube afterwards, please don't. But it's just to have a chat and engage in discussion. Janice?
One of the inequalities that's not been mentioned at all is age in dementia and early onset. Facilities for people with early onset dementia almost don't exist, and it's really been ignored as an inequality.
Yes, no, absolutely. That's often both in practice, as you're saying, but also in research. Actually, what we've noticed is that when people do research, they always say people aged 65 and above, but people with young onset have completely different experiences, and we really need to look at that more. Does anyone else?
Completely different lives and responsibilities as well.
Yeah, they might have double caring responsibilities, for example. So, yeah. Anyone else wants to join in? Young onset? I'm not sure if we have clinicians in this group now. Probably not. James?
The one thing when I've spoken to carers of people with early onset dementia is that the services, as Janice said, aren't driven towards them. and the fact that usually the carers of people with early onset dementia are in employment themselves, and so there's a barrier through employment that they don't have the time. They either won't have the time because they're working themselves, or they'll lose out on potential employment because they're caring. So that it's kind of a catch-22 situation where they can't really win, almost.
Yeah, I think also what's important, as we heard from Warren's talk and others, that family carers or unpaid carers of people living with young onset have different needs as well. Yeah. Yeah, Rosie?
Hi. We have a couple of clients who've got young onset, and I think it's about that person-centred approach. I think, you know, a lot of the time as a provider, we can get caught up in trying to fit clients into a certain box. And I think as a provider, you have to be very open-minded. And the lady who I have in mind, one of them anyway, she actually comes to us 7 days a week, and we pick her up at 6 o'clock in the morning, and we're only a day centre. And I think we've done that to enable that lady to stay at home with her family. And I think as a provider, we must be more focused on, you know, having the open mind, the person-centred approach. And person-centred starts with me, I think. You know, I have to have the right attitude to be able to deliver person-centred care. And it's not just for the person, it's for the families and, you know, their children, you know, to provide person-centred care. We have to have that, you know, holistic approach as well.
Yeah.
Thank you.
Anyone else wants to join in?
Yes.
Can anybody hear me?
Yes.
Thank you. First of all, thank you very much, Clarissa, for this very fascinating 3/4 of a day with a cheese sandwich halfway. I think it's been fantastic. My own personal experience is that, first of all, when people are first of all identified as having dementia, they have a test, often conducted by the GP. And people have told me, you have the test, then you come out of the surgery and it might be confirmed, and there is no kind of post-diagnosis assistance for people who are diagnosed with dementia. That is terrifying. That is a frightening kind of experience. You go into the surgery, you're told about it, you step out the surgery, and you've got no idea how to deal with that. So I think the post-diagnosis stage is very, very important. How people get guidance, how they're given the direction. You know, the word pathways has been used a lot. So, you know, so what are these pathways that people take? That's the question I get from people in Merseyside who are having that experience, and that's not necessarily for early onset. It's probably for slightly later onset. So, what advice can from our research can we give people to go forwards? That's what I would ask. The other thing is, I'm not sure which box I should be in, but I did think the music presentation and the Brain charity was absolutely stunning. And I think it's fantastic you've managed to get that presentation today. And for me, music is one of many different art forms, sculpture, painting. So having a cultural kind of awareness of music, dancing. I was listening to this morning on the radio about ballet dancing and how children are introduced to ballet when they're quite young. So there are all forms of arts and cultures that can be supported through research. So I'm rambling now, so I'll stop. Thank you.
Can I just ask, what's your background? Are you someone caring, or what's your background?
I'm the co-author and an architect of 3 books designed for dementia. 2 are locally inspired, and 1 is about comparative studies in Japan and Finland and Holland. Holland is a really interesting progressive space for these things. So I'm interested in the way design can help. So that's my background.
Okay, thank you.
And I'm, pleased to be here today.
Yeah, no, thank you. Thanks for joining.
Just say to people that I meant to send a message. We've built a dementia-friendly house in Watford, and on the 8th of September, there's going to be an online tour of that. I think I sent you the details, but
yeah,
everybody's welcome.
Thank you. Janice, did you want to say something earlier?
The other, as we're looking at inequalities, the other thing I think everybody involved in dementia care is finding difficult is engaging with Asian and Black communities. It's very, very difficult to bring them in to a place where they can receive assistance for what they're going through. Very, very few are engaged, and that puzzles me, because they must be going through exactly the same problems that the rest of us are going through and need the support, but they very rarely access it. So it's very difficult.
Yeah, I'm mindful Di wants to chip in. Just before Di, just to refer to, we've done a lot of work when I was at Manchester on dementia and recognition in South Asian groups in the UK. And what we found there was that a lot of the care is being held within the family. So it's the cultural recognition of that. But I'm mindful, Di, you're leading the Chinese Wellbeing in Liverpool. So what are your thoughts?
Yeah, just a bit of background. Thank you. Fantastic seminar so far today. It's great. I've been working for Chinese Wellbeing, Service Development Manager, and since 2012, we've been trying to advocate for the needs of BAME communities, particularly the Chinese community, because Chinese Wellbeing is a registered charity that's been supporting the needs for over 30 years. Dementia was highlighted as an issue back in 2012 when we appointed the first dementia champion, along with a dementia champion in the Somali community, as a piece of research really into the needs of BAME communities. And it's from there we've developed a range of services to meet those needs in the Chinese community, and we actually have the only Chinese dementia support network, as far as I'm aware, in the city region. I also chair the diversity subgroup for the Liverpool Dementia Action Alliance. Now, we've had a lot of consultations with health, with local authorities since 2012 into the needs of people living with dementia in our BAME communities. And I've been a part of every single one of them. We thought we'd got somewhere in 2015 when I was the project lead for 4 BAME Dementia Champions, covering Somali, Chinese, African Caribbean, and we did start off with Yemeni and faith communities. And that was running really well until the CCG had a budget cut. And today, that's probably the reason why you haven't got a Somali dementia champion on this seminar. You haven't got an African and African Caribbean dementia champion. You haven't got a Yemeni dementia champion. simply because that funding was stopped, and people don't access mainstream support services for a lot of reasons, language and culture being the main ones. We've actually had to set up something very similar to the Alzheimer's memory cafes. It's called Tea House Reminiscence, because culturally they weren't appropriate. So on the diversity subgroup, we've got Irish Community Care, Mary Sokol House, Chinese Wellbeing, and Back to Life Liverpool. And we cover a range of BAME communities. We still advocate for the needs of BAME communities, and we're still fighting for funding to continue services. So that's where we are today, despite a consultation which we did through the Liverpool Dementia Action Alliance. We've still seen no improvement in the needs of those communities. And you're going back to starting to raise awareness is the issue. If you look pre-diagnosis stage, raising awareness is very key, and that's what the Dementia Champions were all about. So there's a lot of reasons why we're not moving forward, mainly funding.
Yeah, do you feel that COVID might have impacted on these funding restrictions now?
It's certainly impacted in the same way everybody else has talked about today, in terms of carers' needs, in terms of the deterioration in people living with dementia because they're not being able to go out and socialise. So that has happened with our group. We have a dementia network which has got 26 members. Only 50%, and they are carers and people living with dementia, but only 50% have been able to access our online activities, which was a struggle, was a real struggle to begin with, but we've now got 40 people across our services that join us every single week for online activities. So there seems to be a little bit more funding around for COVID-related recovery, and BAME now seems to be a priority for government. It's a shame that so many in the BAME communities have been affected by COVID, but it's now become very clear about the inequalities in care and care pathways.
Yeah, I suppose it's the same with care homes, that they've been put on the frontline news and now suddenly there's supposed to be more support for care homes. But yeah, lots of work on how BAME are disproportionately affected, sadly. Does anyone else have any BAME experiences or any other particular inequalities that they want to raise? So we've just talked about young onset dementia is a huge problem, ethnic minority groups. Anyone else?
Yeah, Clarissa, I'd rather not be on the video, but I can hear you okay, right? Okay, I kind of want to respond to Janice, but obviously to everyone in general. So I put a comment earlier about my mum's from the Windrush generation, which you kindly picked up. So I just want to mention what the issue is for me as a carer, and maybe it will help just widen the knowledge. So my mum came here, and she came in the early 60s to become a nurse, so that's her background. She's seen a lot of inequality, a lot of dementia, a lot of elderly treatment in her work, and she's very affected by that. But one thing I do know from her BAME background is that culturally, she would rely very much on her family to support her, but also to provide social contact, social interaction. She was diagnosed preliminary just before lockdown, and we didn't get a formal diagnosis until August. So that during that time, I've been looking after her. And the most devastating thing is that she's just not been able to see her family, just like people in care homes. So no amount of social activity in the community, whether it was COVID or not, would have helped her. It's the family that was the issue, that she hasn't been able to see the family. And all I'm saying is also, this is more general perhaps than just my mum, but culturally and religious issues can lead to the diagnosis of Alzheimer's or dementia being stigmatized, and therefore families don't want to actually acknowledge it or recognize it, especially the older generation who have got it. And so it's really hard to actually go out and get help for people who don't want to be acknowledged as having this disease. So all I'm saying is maybe organisations need to target the next generation, the caring generation, and actually make it more comfortable for them to get help than for the older person themselves, if that makes any sense.
Yeah, definitely. Di or anyone else, do you have any thoughts on that?
When we first started raising awareness, it was difficult because there is a huge amount of social stigma, but we did it in quite subtle ways. We just sort of slowly introduced people to signs and the symptoms, introduced them to some films showing typical scenarios of people living with dementia and got them talking about it. It was a very long, slow process to break down that stigma, but we feel that we've made huge leaps in the fact that we've now got a dementia network with 26 people from the Chinese community who talk to each other in a peer support way and are happy to share their experiences. When we started out in 2012, that was not the case. It takes a long time to turn that change of thought. So it's patience, it's being given not short-term funding to do a project, which people, grant funders like to do, just throw a project and a short amount of money, years and investment to get where we need to be in communities so that there is equality in care. And breaking that social stigma is a huge, it's still an issue today. So, but we have to start somewhere with it.
Yeah. I appreciate it. It's a really tricky job. In my past career, I've been involved in diversity training and so forth, so I'm quite aware of it from a provider point of view as well. I think it's amazing that you've put this conference on today, Clarissa, and I think it's really helpful. So yeah, but thanks for just acknowledging me. Thank you.
No, definitely. James, do you want to have a, maybe, because you've talked about the pathways before, maybe to share a bit more?
Yeah, I think kind of what we've discussed is kind of came out in our systematic review, didn't it? That regardless of the stage in the pathway, if someone is neglected is the wrong term, but not fully involved from the outset, it's only going to have a knock-on effect as they go further through the system. So if they're having issues at the start, those issues are only going to persist or be exacerbated. So if you don't go to one service, you don't get the post-diagnostic support, you're less likely to make those connections and the networks that you need to then go to community groups or to access specific healthcare or to get an understanding of dementia as a condition and what is available to you. So, and inequalities within itself, because some people are further let down than others, if you like, it's massively important to try and get a handle on who are those people who are at the sharp end of these inequalities so that we can try and improve the situation for them so that they're at least on parity with everyone else.
Yeah. I'm mindful we have one former carer on here. I'm not sure whether she wants to identify herself because she's working with us at the ARC. Are there maybe any other carers who've had experiences of difficulties? Yes, Janice? Go on.
I am an ex-carer of a husband with early onset Alzheimer's. And I also, after I lost him, I started working for my local Member of Parliament, and we learned that if we made the first point of call, the Admiral Nurse helpline, Admiral nurses would put the person in touch with their local carers group. They would also put them in touch with the Alzheimer's Society, and from there they could make other connections which I felt was an absolute godsend to those carers and to the person with dementia, because from there they can access deep groups. The carers have somebody that knows what they're talking about. It all makes a difference.
Yeah, definitely. We've heard a lot that Admiral nurses are really very, very good at what they're doing, but sadly there's not enough funding for them across the country, so it's quite patchy, isn't it? Not everyone can have access to an Admiral nurse.
They do have a helpline, and that's open to everywhere, all across the country. Even if you don't have an Admiral nursing service in your area, the Admiral nursing service can put you in touch with your local Alzheimer's Society or your carers group, which should make a difference. And start, I mean, even with Dementia Friends and Dementia Champions, they can all be connected if you just make the call to the Admiral nurses to begin with. And Admiral nurses are specialist dementia nurses, so they really know what they're talking about.
Yeah, I think one inequality that came out as well, and I'm not sure whether we have anyone living with dementia on the call now, but what we found in some of our work is that having an unpaid carer, having a family carer in itself is a huge bonus, because they often are the ones that look up support groups or sort out things, and they talk to their peers. But it makes us concerned about, well, what's it like for people with dementia that are living by themselves, that don't have that additional support? It's an inequality as well. Right. Is there anything else anyone would like to mention?
Yeah, I'd like to just say a couple of words. I've got a close friend called Professor Dr. John Ashton. He was the former public health officer of Liverpool, Manchester, and he's been quite outspoken about COVID nationally. He once said to me that if the people in Liverpool ate more fish, they would be a lot healthier. Now, it was very interesting what the doctor said today about the importance of diet. And I think he's quite right, really. Diet and exercise. And I know some of the Dementia Alliance people used to go on walks around public parks when they were able to. And I think diet and exercise are very important for us all. And we've got to be thinking, as well as the short term, about the long term of our health, because Liverpool, sadly, as far as national health statistics go, is not very high in the ratings, and I think that is a major issue. And I think dementia is only a part of that. There are other issues, and the doctor earlier today identified some of the issues to do with heart disease, a whole range of things that collectively we've got to try our best to improve. And I think dementia is a part of it. Now, it might sound silly to eat more fish, but in other parts of the world, people do eat a lot of fish. And I think your comparative
we have to be mindful there, though, as well, that there's an inequality in itself, because not everyone might be able to afford good meals and go and buy fresh fruit or fresh fish. So
absolutely,
that's an inequality as well.
That's right. And we can see what's going on in terms of food banks in the city and the problems that people are having with getting, food. It's a really serious kind of issue.
Yeah, I'm mindful that other people are joining us back in now, but if there's so just I'll share it when everyone's giving feedback on their rooms, but I've taken some notes. James has taken a couple of notes and thoughts probably as well. He's nodding, so yes, good, great. So I'm just seeing people appearing again, which is lovely. So we'll just wait another minute or so. Okay. So do we have Kym and Grace joining us, room 1 already? Probably not. Okay. So I think, so we've had, I think music and dementia group is still a little bit delayed, which is fine. So should we have a start with a bit of an overview for room 3? Warren, COVID and care, do you want to give a brief update?
Yeah, happy to. So yeah, thanks again for those of you who joined us in Breakout Room 3. We had a short chat, but a really informative chat about the impact of COVID on care, essentially. So one of the things we spoke about was what people's experiences were. So we had people in the room who were professionals, rural nurses, occupational therapists, researchers, and Paul as well, obviously. And obviously there were lots of challenges. So both carers, both unpaid carers and professionals, people with both, kind of hats on, found it extremely difficult, obviously. Technology has been a massive barrier for dealing with people with dementia in particular. It's just, there just isn't the infrastructure in place, and it's just not suitable when doing like functional assessments, for example. There's been delays to diagnosis. Things like community service work just doesn't really work over the telephone, for example. But what's helped people, particularly the professionals, is seeing this kind of human resilience and seeing teams, a camaraderie between colleagues pulling together. And you'd rather not have to pull together, but actually seeing that come together is quite rewarding, and getting through it. Then we also spoke about digital, and kind of on the back of my presentation around how we can meaningfully incorporate digital alongside more traditional methods of support. And obviously, again, digital just doesn't work for some things, but it does work for others, and it's about supplementing rather than replacing. In terms of lessons that can be learned from the pandemic and what we can kind of carry forward into the future, is that we need to identify the unpaid carers. There was a lot of talk around the front line, and they were doing a fantastic job. But for me, I've always said the real front line is more advanced than that. It's the unpaid carers keeping people well and out of hospital at home. So they need identifying, supporting, and letting them help the professionals and work alongside them, and allowing them to see their loved ones. So we've all struggled, haven't we, with lack of face-to-face contact. But like Paul was saying, he hasn't seen his mum properly since the summer, so that's taken its toll on her and him. So can we put better infrastructure in place to facilitate that as well?
Yeah, great. So some really interesting discussions there. That's great. Okay, so that was room 3. Do we have music and dementia now? Otherwise, is Asan back in? I know Masoud has to leave.
Yeah, I'm here.
Yeah, do you want to give a quick update on your discussion?
Okay, I joined partway because of my technical challenges, but yes, we were discussing how sometimes the care of an older person can be fragmented because they are seeing various specialists, and for the person receiving that care, it may seem chaotic and uncoordinated, and sometimes that can result in unintended consequences and harm because one doesn't know what the other has been doing. But certainly results in confusion and misunderstanding for the person receiving care. And various examples were given. On the other hand, also examples were given of how things are beginning to change, and increasingly there are now people working in teams, and also there is a drive to try and ensure that information collected in various parts of the health and social care system can be accessible to those who need that information so that they can make a more meaningful and useful plan with an older person.
Yeah, okay. Is there anyone, was it Debbie who was joining that talk to further share? No? If not, I'm just going to give a brief summary on what we've discussed in our breakout room 2. So we've been talking about inequalities in dementia care. So James and myself were in the room, and we've had some interesting points raised on young onset dementia in particular. So age is a big factor in how care, but also the diagnosis is affected if someone at the age of, say, 40 might get a diagnosis or not, because they're delayed, and general practitioners usually wouldn't assume that someone at such a young age has dementia. So there's delays, but there's also services not being age specific, and also family carers or unpaid carers have different needs than someone that's maybe 80 and caring for someone. So young onset dementia is an inequality that was raised. We've also had a good chat about BAME, so people from minority ethnic groups, and we've had Chinese Wellbeing, who was sharing some of her thoughts on the third sector and what's involved in raising awareness around dementia in different minority ethnic groups, but also flagging up that there's funding issues. So how are there going to be enough people going out into the communities and raising awareness about dementia? And then we've also had a bit of a chat about Admiral nurses. So I'm not sure whether everyone is aware of it, but so Admiral nurses are across the country, and they provide a good kind of link in after the diagnosis to post-diagnostic care services. But also, I think one thing that struck me in doing our research as well, having a family carer or unpaid carer or not having one is an inequality in itself, because if you do have one, they're usually there to link you up with support groups and finding out all this information. But if you're on your own, you're risking not accessing the right care or not even getting a diagnosis at the right time. James, is there anything else you'd like to add from our room discussion?
I just thought it was interesting to talk around young onset dementia in particular, because there's so many services, and services seem to be designed with older people with dementia in mind, rather than being reflective of a seemingly growing number of people who are being diagnosed with dementia earlier on. And through our interviews, we've kind of seen that that is an issue, reflected with carers being of employment age as well. And so they're in a catch-22 situation where they can't provide care, or they can't work to provide the money that they need to then provide for the person they're caring for. So it's a bit of a difficult situation the carers are in that situation.
Yeah, definitely. So that was a little summary of our discussions, and we've got Grace. Do you want to give an update on your music and dementia group discussion?
Yeah, sure. And Kym, feel free to jump in if I miss anything. We were talking about how you make music happen in care settings for people when you might be looking at a very culturally diverse group of people. So we're talking about the ways in which you might apply music and work with it and flex with it in order to reflect cultural differences and cultural crossovers. We also talked a bit about evidence and using appropriate evidencing and monitoring and evaluation tools when working with a non-medicalised intervention such as music. We also got on to talking about digital engagement. I think that follows on from one of the presentations before we went into the breakout groups around what's manageable for people in terms of online experiences and their experiences with their dementia, and how you can enable people in their own right with what's available to them in front of them in that moment to get music going if they're not already doing that. I think that's a bit of a top line summary. Kym, I don't know if there's anything I've missed.
No, that was a great whistle stop tour. Actually, much more much more in detail than I would have given. Yeah.
Okay, great. So I think we're at a close now. So this has been about 4 hours of lots of talks, lots of information. I just want to thank all of the speakers for prepping for this, making their time, and everyone for attending as well and joining us in the breakout room. So I truly hope you've taken some interesting nuggets of information And yeah, and keep in touch with the Liverpool Dementia and Aging Forum, because we've got lots of events coming up. Okay, so a big thank you to everyone. Okay, thank you.
Thank you. It's been wonderful.
Oh, thanks.